A very good evening to one and all present with us today. I am Arpita from Clarinet, and I welcome everyone to a very interesting session on the topic Basics in Total Hip Arthroplasty. It's presented by the Tamilnadu Orthopedics Association, and we, Clarinet, the digital partner of this program, are very proud to be associated with the same. So here I present a small video. This will not take much time, and we shall wait for some more participants to join in, and then we shall start. So meanwhile, I will just share the video of Clarinet. What is it all about? Thank you all for watching the video. Clarinet is India's largest live digital CME platform only for the doctors, and it is a medical content generated platform. So I would request everyone who are there, if you can please log in the Clarinet platform. It's available in the App Store and the Google Store. So we are not left with much time to start. We are just waiting for a few more attendees to join in.
வியூ மாத்தலாம்ல பிரசன்ட் ரிவ்யூ நோட் இருக்குங்க எங்க
இல்ல அங்க சேஞ்ச் பண்ணலாம்
ஸ்டாப் பண்ணிட்டீங்களா? என்ன இது வரலையே? So, shall we start?
Yes, sir.
Yeah. So, good evening to everyone. So, I take great pleasure in welcoming you all for this OASIS instructional course lecture. At the outset, I wish to thank the office bearers of the OASIS for having given us this opportunity for conducting this prestigious OASIS ICL in Chennai. So this is going to be a offline and online hybrid conference. So I wish to thank them. I have great pleasure in welcoming the president of the OASIS and my dear good friend, Professor Dr. Selvaraj from US, where he is there. And it is quite early morning and he is joining us. Sir, welcome, sir. So I welcome our Secretary General of OASIS, Dr. Anin Nambikutti, for this conference. I take great pleasure in welcoming the President of the Tamilnadu Orthopedic Association, Professor Anthony Vimalraj, for this. Welcome, sir. And Professor Dr. P.T. Saravanan, the Secretary of Tamilnadu Orthopedic Association. So I also welcome Professor Dean Mohammed Ismail, the Director of Madras Medical College Institute of Orthopedics. I welcome you, sir. I welcome all the senior faculties who have loads and loads of experience. So I welcome you all for this conference. And I also welcome all the delegates who have joined us in great numbers. Last I heard it was more than 250. And physically we have got, even before that, we have got more than 50 people who have joined us. And it is going to be interesting that there is going to be a live demonstration of the templating of hip arthroplasty, I think, which we are doing it very rarely. So I welcome all the delegates for this conference. So I take this opportunity to thank the Deputy Johnson & Johnson for taking up this project program and doing it very successfully. I thank you. And I thank Clarinet for doing a wonderful job of a digital partner for this and doing this conference successfully. So I welcome you all once again for this wonderful conference. So with that, I request Professor Dr. Selvaraj to give his inaugural address. Over to sir.
Thank you, Singhi. A very good evening to one and all. The dynamic Secretary General of OASIS, Dr. Anin Nambikutti. For once, I see him not driving and he is seated in his house, or else he'll be on the move. President of Tamilnadu Orthopedic Association, Dr. Anthony Vimalraj. Secretary of TNOA, Dr. P.T. Saravanan. The organizing chairman of this OASIS ICL in Tamil Nadu, and the Vice President of TNOA, Dr. Singara Vadivelu, President of Madras Orthopedic Society, Dr. Navaladi Shankar, Secretary of Madras Orthopedic Society, Dr. Karu Shanmugha Karthikeyan, and Director, Institute of Orthopedics and Traumatology, Madras Medical College, my good friend, Dr. Dean Mohammed Ismail, respected teachers and friends. As the President of OASIS, it's my pleasant duty to be a part of this ICL titled Basics in Total Hip Arthroplasty. When we were postgraduates, total hip replacement was a rare surgery. If you had watched 4 or 5 in the whole tenure of my post-graduation, that's a big thing. But nowadays it's not so. Scenario today is totally different. Even in small centers, total hip replacement is taking place on a regular basis. With the advent of this government scheme, it has become even more a common surgery. Every game has a fixed set of rules by which if you play, you are always safe. Surgery is no different. You have to plan meticulously and execution should be perfect. These all are required for achieving optimal results. The topics for this instructional course lecture have been selected by the organizing chairman very painstakingly, and he himself is an extremely talented and versatile surgeon. The faculty is a blend of stalwarts like Professor Govardhan and Dr. Vijay Bose, and enterprising young surgeons, Dr. Cherulathan, Dr. Thirunarayanan, Dr. Rajkumar and Fakhruddin, and an overseas faculty, Mr. Martin. I'm sure the course will provide a wealth of information on the basics of total hip replacement. I'm happy to formally inaugurate the OASIS ICL on total hip, the basics of total hip arthroplasty. Thank you very much.
So thank you, sir, for your motivational and congratulatory message. Thank you very much. Now I invite the Secretary General of OASIS, Dr. Ani Nambikutti, to give his address. Over to Dr. Ani.
Good evening all. Respected President of OASIS, Selvraj sir, Organizing Chairman, Singarabadi sir, TNOA President, Secretary, all other dignitaries on online and offline. I think ICL has taken off very well, and I think it is a platform now for people far off to hear from the experts. And Singar sir has taken pains to bring all the experts in total hip arthroplasty into this, and I congratulate sir for that. And I would like to announce a few programs. The next ICL will be on 1st March from Andhra Pradesh, which will be on distal and radius fractures. Next, we are having a program with partnership with Bombay Orthopedic Society called Viro Global. As part of their annual conference, we'll be having a 2-hour program from 4:30 p.m. to 6:30, which will be a webinar. On 27th of March, Sunday, we are having a program with topic on fractures around the shoulder. And I think the scientific chair is our organizing chairman itself, Singarabadi sir. And next program will be the OASIS Trauma Con. We are hoping that it will be a physical program. The Kerala is going to host it, and I think it is in Kozhikode. The topic is fractures around the knee. The dates is April 30th, 2022. And I hope this program all the best. Thank you.
Thank you. Thank you, Dr. Ani, for all the programs of OASIS, and it is doing excellent job in teaching and educating the entire OASIS and everyone. So now I invite the President of Tamilnadu Orthopedic Association, Professor Anthony Madras, to give his President's address.
Respected President of OASIS and my teacher, Professor Selvaraj, respected Secretary General of OASIS, Dr. Professor Anin and Kuti, dear Secretary of TNOA, Dr. P.T. Saravanan, Vice President of TNOA and Organizing Secretary of this OASIS ICL, Professor Dr. V. Singaravadi, respected Director of MMC, Professor Din Muhammad Ismail, the other office bearers of OASIS, TNOA and MOS, and my respected teachers and dear faculties and my dear friends, good afternoon. OASIS is conducting the instructional course lecture once in a month in the first Tuesdays among the OASIS states by rotation. First, for this, I should congratulate our President and Secretary of OASIS to conducting this OASIS ICL in a very fantastic manner. Then I take this opportunity to invite you all to the postponed TNOA Con 2022 Trichy in the 3rd week of March. That's in Srinivasan's Medical College, Trichy. I congratulate the RNIC Secretary of this OASIS ICL for organizing this OASIS, this IC instructor course lectures in a fantastic manner. Thank you, Honorable.
Thank you, sir. Thank you. Thank you for those nice words. Now I invite the Director of Institute of Orthopedics, Madras Medical College, to give his address. Professor Dean Mohammed Ismail.
Respected dignitaries of the dais and overseas, it's good evening from India time. This is an excellent program of OASIS instructional course lecture, and Professor Singaravadi being very interested in the joint replacement. He's really conducting in a very nice way. Almost all our postgraduates, they start doing total hip and total replacements once they finish their course and go to their native places. Even total hip replacements are done in all headquarters hospitals by our postgraduates. The exposure of postgraduates doing their course to do the surgery is enormous. But by conducting this program, Professor Singaravadi has got some vested interest. He told me, say, everyone has started doing this total hip replacement, but when they come, the patients come for revision hip replacement, we can see the cement down up to the knee joint, making a job very difficult. And he was very keen to train the postgraduates and young surgeons the correct techniques of total hip replacement and total knee replacement. So by attending these instructional course lectures, I'm sure the young orthopedic surgeons will be able to do a very good job, and they can continue their replacement work in an excellent way. So I congratulate the organizing chairman, Professor Singaravadi, for his enormous effort in conducting this program. Thank you.
Thank you, sir. Thank you for those nice words of appreciation. I really appreciate it. Now I request Secretary of our Tamilnadu Orthopedic Association to say a few words.
Good evening, one and all. So, respected OASIS President, Secretary General, TNOA President, Organizing Chairman and Organizing Secretary, and distinguished delegates, online and offline, and faculties. So, I thank the OASIS for giving the TNOA this opportunity. We have one more opportunity in August. Next program, TNOA is going to conduct on trochanteric fractures. Hope that one will be also not hybrid, that going to be a physical at Coimbatore. So I take this opportunity to invite you all to the TNOA Con 2022. It's postponed. The new date is 18, 19, 20 March 2022 at Trichy, Srinivasan Medical College. So our president's theme is focused clinical and surgical skills, continuous update. This program also based on the theme. So I once again thank the OASIS and welcome all the delegates. Thank you all. Thank you, sir.
Thank you, Dr. P.T. Saravanan. He has traveled all the way from Kanchipuram, and he is such a dynamic secretary for us who has been bringing us the A.K. Gupta Trophy for the TNOA, is greatly instrumental in that. He has worked so hard, and almost everyone knows about his work culture, and it is very, very difficult to emulate. Thank you, Dr. PTS, for having come here and then addressing us. So now we have completed the official function of the OASIS ICL. Now we'll go to the business part of that. Now we'll start with templating in THR. Templating is very, very important. So planning is very important for the surgery to succeed. For that, now I invite Dr. Cherladan. He has also got the physical exercise, practical exercise for the first 50 people who have joined to do the templating, because whatever we listen to, nothing like doing it ourselves, which will really make us to do for the next case if you have to do it. So over to Dr. Cherladan.
Forward, backward, forward.
So all the questions we can address after each topic so that the questions will not be forgotten. Those people who are online, they can just in their comment box, they can just type the questions so that we'll ask the faculties, because all the faculties here are experts in this field, and we want to pick their brains and get the maximum out of them. So I request all the people who have assembled here to ask as many questions so that we can get our doubts cleared, as well as people who have joined us online to post their question in the comment box, so that all the questions after each topic will be clarified then and there, and we'll get the maximum out of it.
Thank you, sir. Respected teachers, seniors, and friends, a very good evening to one and all. Now, before I begin, I wish to express my sincere gratitude to Professor V. Singaravadivellu sir for giving me this opportunity to talk on templating in total hip arthroplasty. Before I begin the presentation, I would request the delegates who have received their envelope to kindly check the contents in it. There will be an A3 sheet with an X-ray of pelvis, and each table has got 2 sets of template copies, the acetate sheets, and there is marker pen, scale, protractor provided along with OHP sheets. So as we go through the slides, please follow me through the steps of templating so that we can complete both the demonstration as well as the presentation together. So we'll move on. So why templating is important? We all know that template helps us to predict the size of the components that will be implanted during surgery, but it also gives us additional information. It helps us to know the position and insertion depth of the components during surgery, and it will help us to know about the potential difficulties that can occur during the surgery, so that we can plan for the remedial measures in advance. And ultimate aim in total hip replacement is to reproduce the patient biomechanics. So these are the types of templating which are available right now, broadly classified into 3-dimensional and 2-dimensional templating. Now, 3-dimensional templating is based on CT films, and we need commercially available softwares for it. The one example will be Modicast 3D, but the other part, the 2-dimensional templating, can be done with so many methods. The most common methods are the acetate sheets, which can be superimposed on conventional X-ray films or digital X-ray films, or even digital screens which are available. Like we can do templating on a laptop screen, on an iPad screen, or a tablet screen, whichever can be is available. And there is also another method using dedicated software like TraumaCAD, OrthoView. These can be integrated into the PAC system that is available with the radiology department. So the X-ray is retrieved, templating is done digitally, and a copy is taken so that which can be used as a reference material during the surgery. Today we will concentrate on acetate sheets and digital films. We will do templating on this. For ease of availability, we have given printout in a paper. You can do the same here as well. So what are the problems that can cause inaccuracies in templating? The first important point is that any X-ray is just a 2-dimensional representation of a 3-dimensional structure. So we will have a few message missing there. So that can lead to some inaccuracies, but we can address it. And next comes image magnification errors and also distortion due to the X-ray projection or the rotation of pelvis and femur. There are certain measures to control this inaccuracy, which will improve the accuracy of templating. With regards to literature evidence, how accurate is templating? There is wide variated reports. For example, for the cup size, the accuracy varies from 16 to 62%. Likewise, for the cemented and uncemented stem. But if you refer to this particular article by Morris Mueller, he has committed that by using a systematic method of templating and correcting the magnification errors, he was able to predict the femoral size in 92% of the cases and the acetabular size in 90% of the cases. So this presentation is based on his method, and another author, namely author Thierry Scherling. He has given a 4-step approach to the templating. We will see each one in detail. So the first is identifying anatomical landmarks. So the landmark shown one here is the medullary canal, which is easy to identify. And we all know that it is classified based on the door type. The next will be the outline of greater trochanter, the saddle point, which is nothing but the junction of the superior border of the femoral neck with the greater trochanter. Now that can serve as an important landmark during surgery to assess the insertion depth of the femoral stem. The next is the outline of the lesser trochanter and the acetabular roof, also known as the sourcil. And the last is the radiographic teardrop. Now I find that the postgraduates have some difficulty in understanding what exactly is a teardrop. For that, I have added this image. This is nothing but a coronal CT image of the pelvis taken at the level of the hip rotation center. You can see that there is a teardrop-like structure here, where the lateral border is nothing but the true floor of the acetabulum, and the medial line is nothing but the lateral wall of the pelvis. They both meet inferiorly in a U, forming the radiographic teardrop. Hope it's clear now, because this is one of the commonly asked questions in PG exams. What is a radiographic teardrop? And people find it difficult to describe it. So this is how we should describe it. Step 2 will be evaluating the quality of radiographs. Now, any pelvis X-ray cannot be used to do templating. There are specific instructions which you have to convey to the radiographer to take a pelvis X-ray. The first important thing is that we all know that the patient will be made to lie supine on an X-ray table. There is another important component of this table. You can concentrate here. This is known as the bucket tray. Usually the radiographer places the cassette in this tray to take an X-ray. But when we need an X-ray for templating, we have to specifically instruct the radiographer to place the cassette immediately beneath the patient's skin, because that will avoid the magnification error. The next point is the distance between the patient and the X-ray source. That has to be in the range from 100 to 120 centimeter. The reason we will see shortly. The next will be the central beam of the X-ray should pass through the symphysis pubis and not the sacral promontory as it is usually done, because that will reduce the distortion in the X-ray. Next will be, we have to make sure that both ASIS, the anterosuperior iliac spine, should be equidistant from the cassette, so that will prevent any rotation in the pelvis. And the last instruction should be that the leg should be rotated internally to a degree of 15 to 20, so that we get a true profile view of the femoral neck. The other instructions where we assess the quality of X-ray, the first landmark is the obturator foramen. We have to make sure that both obturator foramens appear equal in size and shape, so that this will indicate there is no pelvic rotation. And the next landmark will be a vertical line passing through the symphysis pubis, which is marked 2 here. It should pass through the center of the sacrum, which is marked 3 here. So that again shows that there is no pelvic rotation. The last landmark will be the distance between sacrococcygeal joint and the top of the symphysis pubis. Now this distance should fall within this acceptable range, which is separate for men and women. If this distance is increased, it indicates that the pelvis is tilted forward, like in an exaggerated lumbar lordosis, or if it is reduced, it indicates that the pelvis is tilted backwards, like the opposite deformity, kyphosis. In such situation, we have to adjust the position of the patient and the X-ray tube so that we again get this distance in this range. Only then we will be able to avoid projection errors. Now, how to estimate magnification? Now, for sake of understanding, just imagine a cone of light emitting out of a torch. An X-ray is a very similar phenomenon. If you consider this to be the X-ray source and this as the patient's body and that to be the cassette, you can appreciate the amount of magnification that will happen, right? How to reduce this? There are 2 methods. First is to increase the distance between the patient and the source and reduce the distance between the patient and the cassette. Now, consider this image and this image, you will be able to appreciate that the magnification is significantly reduced in the second method. To make this easily understandable, I've added this video. Now, the shadow represents the X-ray image and the bone represents the patient's body on the X-ray cassette. And the white paper is the, assume that the white paper is the cassette. Now, if you increase the distance between the cassette and the X-ray, see what is happening. The magnification is increasing. Are you able to understand this? So we have to keep this in mind. We have to try to control this magnification. And this is a magnification chart published by Maurice Mueller. And this chart will be very useful in scenarios where only conventional X-rays are available, because like in digital X-rays, in conventional X-rays, we can't adjust the magnification while taking a printout. That option is not available there. So when you have only conventional X-rays, you can use this table where he has predicted He has predicted the amount of magnification that will occur based on these two distances. The mark D is the measurement between the source and the patient's body, and the distance C is between the plane of the hip and the plane of the cassette. Now, this distance C cannot be altered because that depends on the patient's body size. For obese patients, it will be more. For thinner patients, it will be less, but you can alter the distance D, right? So using this tabular column, if you are able to calculate this distance, and if you want a particular desired magnification, for example, some templates come in a magnification of 1.15. Some templates come in 1.2. So you know you have the template sheet with you, you see the magnification film. So to establish 1.2 magnification in a patient where the distance C is 20 centimeters, you have to set it at 100 centimeters. Is it clear? So this article is available, full version is available in Google. You can download it and you can use it while taking X-rays. Now, how to assess femoral neck length? Now, femoral neck length biomechanically translates into the horizontal offset of the stem, which is very important to restore the patient's biomechanics. Now, to get a true neck length, it is very important that the plane of the femoral neck lies parallel to the cassette. Only in this situation, we will get a true length. When it is more externally rotated or more internally rotated, there will be shortening of the neck. It is always better to keep this projection of the lesser trochanter in the range of 3 to 5 mm so that we do not cause an error in rotation. Now again, this is another video. To start with, it is in excessive external rotation. You can see that the lesser trochanter is seen very widely. Now observe what happens as we slowly rotate. So when we slowly rotate and reach this point where the lesser trochanter is ideally seen, we get a true neck length. But if we continue to rotate it, again, there a shortening happens. Hope you're able to understand this now. So rotation of femur is very important to avoid this error, a correct rotation of femur. Now we have to know about the calibration objects. These are nothing but metal spheres, like the one I have in my hand right now. These are available in all hardware stores and they come in specific measurements, 20 mm, 25 mm. It is very easy to get. Please have one of these balls with you while taking this X-ray. And how to use it? It can be attached using a radiolucent flexible shaft like this, or a metal block with a slot for the ball, or special straps available like this. But if none of these are available, no problem. You can just stick this ball to the patient's body at a desired height using a plaster. Now, what is the desired height? This is the desired height. See, it should be in plane or in the same plane as the hip joint. And the ideal position is that it should be placed in between the patient's leg, close to the symphysis pubis, so that we reduce the amount of projection error. But this situation is not always possible, especially in female patients. So in such situations, it is accepted to keep it over the trochanteric region. But we have to keep in mind that this may cause a projection error. So the ideal method is to keep the ball here. Step 3 will be defining mechanical references. We have 3 references: determination of rotation centers, femoral and acetabular offset, and limb length discrepancy. Now, what is rotation center? It's nothing but when the anatomy of the hip joint is preserved, the sphericity of the femoral head and the concavity of the acetabulum will meet at a common point, right? They are literally concentric circles with a single common center. Whereas if the joint is destroyed like this, there will be relative displacement of the head of femur from the acetabulum, and we will have 2 different rotation centers. This rotation center will match the acetabulum, and this rotation center will match the femur. We will see them shortly during our templating exercise. The next is to determine offset. Horizontal offset is nothing but the distance from the center of rotation to the anatomical axis of femur. This is the femoral offset or the horizontal offset. The acetabular offset is nothing but the distance from the center of rotation to a vertical line passing through the teardrop. When these 2 measurements are put together, it forms the combined offset. Now, this is very important because this factor controls the relative placement of the trochanter with regards to the pelvis, which is very important in hip biomechanics. Now, the third point will be the limb length discrepancy. Just concentrate on this measurement number 5. The vertical distance between the inter-teardrop line and a fixed landmark on the lesser trochanter. Either it can be the top or the middle or the lower. That depends on the surgeon. But one fixed landmark on both sides. Now we have to measure the difference between these two, which will give the hip length discrepancy. Now it is very important to correct limb length discrepancy. Otherwise, there will be abnormal stress on the implant. We will do all this during the demo. The final step is choice and positioning of implants. So which side to template? I think now you can take the templates available with you. Hope it's okay. Just follow the steps. As I do, you can proceed with the templating. So when the anatomy is relatively preserved, even on the pathological side, you can template on the pathological side itself. But if the anatomy is grossly distorted and we have a normal side available with us, you can template on the normal side and replicate the results on the abnormal side. But in bilateral conditions, we have two options. One, if one side is relatively preserved, we can choose that. But if both are badly damaged, then you can use either of these two methods, Ranawat method or Pearson's method. These two methods are used to identify the hip rotation center. Now, how to use the Moose circles and how to assess magnification. Now, this is an example of a template sheet available with us. And these concentric circles are the Moose circles. They have the dimension of the circle mentioned here and there. And you can use either the femoral head or the acetabulum and match this contour of the circle with the contour of femoral head to determine the rotation center. Now, the next point to verify with regards to the template is the magnification. Here you can see that it is mentioned 120% magnified. But how true it is? How to verify it? We have to place the ruler close to it and match the 0, mark of the ruler and the template sheet. And when you move down to the 10 centimeter mark, you can see that it will match with the 12 centimeter mark on the scale. The 10 centimeter on the sheet will match on the 12 centimeter on the scale, which will confirm that it is 120% magnified. Now, why this step is important? Because in certain situations, the copy we get may not be as accurate as the original template. It is usually Xeroxed. The template itself can be Xeroxed on an OHP sheet. In such situations, the magnification may change. So we have to control this error as well. So assessing the quality of radiograph for templating. The same X-ray is available with you. It's available on the table with you. So again, the first step is to make sure that the magnification is correct. You can see the metal ball down there. It is 20 mm in diameter. Now place a ruler over it and see how it is, what is the measurement. It will be measuring 2.4 millimeter. That indicates that this film is 120% magnified. Now we'll move on to the next landmarks, the Operator Foramen. When they are equal in size and shape, we are happy that there is no rotation. And as we saw in the earlier slides, the distance between the sacrococcygeal joint and the symphysis pubis, that should be within the reference range. And the next thing is you draw a vertical line along the symphysis pubis. It should pass through the center of the sacrum. This also indicates there is no rotation of the pelvis. Next, we move on to mark the other landmarks like the teardrop on both sides, the inter-teardrop line, right? And then other landmarks. And here you can see that the left side is destroyed. So we will template on the right side and replicate it on the left side. And this is the anatomical axis of femur on the normal side. And the other landmarks, lesser trochanter, greater trochanter, right? And we are able to see that there is some amount of length discrepancy. Hope it is clear here. This hip is actually short when compared to this hip by 2.5 centimeters. You will be able to measure it in the film given to you, right? We should keep this in mind and we will address it while we place the final components. Now, how to mark the hip rotation center? Right. You should use the Moose circles. Hope the circles are not given. Then you can roughly mark a hip center. You can roughly mark the hip center. I'm using the circles here. I'm matching one particular circle to the femoral head. Since the joint is preserved on this side, I'm just using one parameter. So I'm marking the femoral rotation center, which is equal to the hip rotation center. So I'm marking it. So this will be the rotation center of this particular joint. Both acetabular rotation center and femoral rotation center are the same point here. Now, landmarks for templating acetabulum. There are 5 important criteria which we should remember for acetabulum. The first important point is that the infromedial part of the cup, like shown here, it should be placed just infrolateral to the teardrop. Okay, and the medial border of the cup, shown here, should be placed just lateral to the ilioischial line. If it goes medial to it, it indicates perforation of the medial wall. And the superolateral part of the cup should match the sourcil, and the center of rotation should match the center of rotation we have marked here, right? And the last landmark will be the abduction angle. I think the protractors are given to you. You can use the protractors as a guide to rotate the acetabular component to set your desired angle. 40 to 45 degrees is usually acceptable. Now we have to replicate the hip rotation center on the normal side to the abnormal side. How to do it? If you look here, there is a vertical distance between from the center of rotation to the interteardrop line, and a horizontal distance from that point to the teardrop. You can have 2 measurements. Now replicate this on the opposite side, the horizontal distance first, and take the vertical distance first, vertical distance next, and you will have a rotation center. Now this had been the rotation center before the joint was destroyed. Hope you're able to understand. This was the original rotation center before the joint went into destruction. Now our templating will be based on these 2 rotation centers. How to size the acetabulum? Based on the landmarks I said in the previous slide, you can start templating the acetabulum in your, you can observe it and you can do it there. So I'm starting with a random size, starting with 52. First step is to match the rotation center, and then look at whether it is matching the contour of the acetabulum. It appears small. I moved on to the next size. It is 54. This also appears a bit small. So I'll move to size 56. This is 56. First, matching the center of rotation. This seems okay. The inferior edge, the medial edge, the superior edge, all seems to be okay, and it is matching the center of rotation. And you have to note that there is some amount of uncoverage here. You have to remember this amount of uncoverage because the same will happen on the opposite side and during the surgery. Because in order to match this, in order to control this uncoverage, we have a tendency to tilt it more vertical. Then the cup will become vertical, right? So now you have, there is one potential problem which we should keep in mind during the surgery, right? Now I'll move one size up. I'll try to see whether the 58 cup fits here. This also seems okay, but after matching, you can see that there is so much amount of normal bone that should be removed to fit this cup. So there will be removal of more bone. So I think I'll stick on to 56 and use the 56 cup on the opposite side. Now I already have a rotation center there, right? I have replicated this center there, and I will match that center, adjust the abduction angle, and I will trace this on the X-ray or the OHP sheet. You can directly trace it on the paper available with you, right? So this completes acetabular templating. Now, understanding femoral template. There are a few points we have to keep in mind with regards to the femoral template. The first important landmark is the axis of the shaft. This should match the anatomical axis of the femur. Next comes the stem options available. We will see about this detail in the next slide. And these are the different neck options available. Each dot noted here is the rotation center for that particular femoral component, and it can vary from -3 mm to +16 mm. So many options are available, right? So we can adjust the neck length. Next comes the neck resection line, and this line is the stem insertion guideline. We will see all these in detail. Okay. So this was what I was discussing in the previous slide. See, we should understand which type of stem will be given to us. Now, this particular company gives 2 options, a standard and a high offset stem, but there is no change in the neck shaft angle. It is just a parallel line, and in high offset, the head and neck is shifted more medially. That's it. Whereas in this particular company, you can see that there is a change in the neck shaft angle. So this will vary depending on the company we use. So we have to understand this, because this lesser angle will be a varus stem, and that can be used in various situations. But if you don't comprehend this, there will be mistakes. I'm sorry. Yeah. And please concentrate here. Many company give this option. There is a K-wire-like device which can be inserted through the taper part of the trial head and neck. And this can be measured from the tip of the GT to give a rough guide regarding to the insertion depth of the stem. We will see again this. Now, how to go about templating the femur. So we'll start with size 0. First step is to match the axis of the stem to the anatomical axis of the femur. That is the first step. And you should slowly bring it down, as if inserting the stem into the canal like we do in surgery. Slowly bring it down. And this line, the insertion line, will give a guide to me. Usually it is stopped at the level of greater trochanter. Usually. But we can change if you want, right? But usually it is stopped there. And now I see that there is, this stem appears a bit small. So I'll move on to the next size. This is size 1. Same method is repeated. Axis is matched, slowly brought down. And I stop it at the level of this insertion guide. And this appears okay. The match is okay. And I'm getting a match at the rotation center. And this will be the neck cut guide. And this matches the 0 neck length. Okay. But still, I will try one size bigger to see whether that fits better than this. Size 2, same method, bringing it down. This also appears okay, but if you closely observe here, there is more endosteal contact here. So 2 problems can happen. Either I will have to remove more bone to seat this stem, or it may get stuck in the middle. The stem may not be seated fully. So I think I will go back to size 1 and use it. Check it once more that I'm more comfortable with it. Same method, match the parameters. Determine the neck cut level from the lesser trochanter. You can mark that. The stem insertion guide, that's also okay. Now I will use it on the opposite side. With the same method, I will match the axis first, slowly bring it down, and make sure that the insertion height guide will match the trochanter, tip of the trochanter. And now I have a different center of rotation. See, on the normal side, the center of rotation was the same for acetabulum and femur, but now it is different. I will make the neck cut mark and the rotation mark. Now in this picture, you can see that I have drawn the outline of the stem, and this is the femoral rotation center and this is the acetabular rotation center. Now what is the relation between these two? Now you can see that there is a vertical displacement and a horizontal displacement between these two. What is the meaning of this? If you remember during the first slide, I told that there is a shortening of 2.5 centimeter on the affected side. Now, after implantation of the same size components during surgery, this rotation center will be brought here. Now, measure it. It is 2.5 centimeter vertically and 1 centimeter in the horizontal aspect. So, if I use the same components, this center of rotation will be brought here. So I will be gaining 2.5 centimeter in length, and I will be increasing the horizontal offset by 1 centimeter, and thereby I will match this center of rotation here. In other words, I will be reconstituting the native hip biomechanics. Hope it's clear, right? This is all done in OHP sheets. I have made a trace of the pelvis and the intact femur and the normal hip joint on one film, the acetabular component on one film, and the femoral component with the neck cut already made. Just assume, I just marked it, okay, on this one film. I have matched these 3 films so that my center of rotation matches here. Now, this is how the post-op X-ray will look if we use the same size components. And we have so much details here. We have the stem size, the cup size, the cup abduction angle, the stem size, the head size, the neck length, the pre-op limb length discrepancy, the neck cut level from the lesser trochanter. We can also mark this. And the stem insertion depth. Here we saw that it is tip of the greater trochanter. Now what is missing here? Anteversion. Both acetabular anteversion and femoral anteversion is missing here because that is a three-dimensional concept and that we can't do in a two-dimensional structure. That has to be done intraoperatively. So if you have this in an X-ray lobby before going to the surgery, it will give us a lot of idea how to go about. And if I grossly deviate from this steps or these sizes, that should indicate me, that should make me think something is wrong. I should reassess it. So much potential information or information about potential problem is available from templating alone. So it will bring down the difficulty during surgery. So here in one slide, acetabular rotation centers are marked, cup is marked, stem is templated, neck cut is determined, insertion height is determined, and the same is replicated during surgery. And restoration of hip rotation center. Fine. So in conclusion, it is important to correctly identify the anatomical landmarks and anticipate difficulties which may occur during surgery and plan accordingly. For some cases, there may be much uncoverage of the cup. So we may need to plan for augments or bone grafts, likewise, for example, okay? And a good templating method and a proper surgical technique will definitely give better outcome and patient satisfaction. So these are the reference articles. These are full version is available in Google. You can download them. Thank you.
Thank you, Chairman. That was a wonderful demonstration of how templating must be done. And I hope that all the people who have been doing the practical exercise would have realized, and those people who have listened also. As far as the templating is concerned, if not for the, because even templating must be done for the total knee, but most of us, we are not doing it. But for a totally replacement, most of us, we are doing the templating, which is very, very essential. And it is very, very important aspect of doing a total replacement. Thank you. Any questions?
Yeah, if there are any questions.
So if there are no questions, I thank you once again. And
thank you very much, sir.
Professor Anthony, the President of Tamilnadu Orthopedic Association, to honor Dr. Chairman. So, thank you. And now we move on to the next topic. So before that, I wish to introduce Mr. Martin Zimmerman. So he has been not a stranger for our India, and for so many arthroplasty conferences he has been participating, and he has given us so much of knowledge. So he is a Swiss citizen, and for more than 25 years he has got experience in orthopedics, and he has worked in so many other companies, and now he is at present with Ceramtech, which is the company which manufactures ceramic components, bearing for almost all companies like Depu or Smith & Nephew or anything you take. The ceramic components are manufactured by them. And he has got so much of knowledge in the arthroplasty, the engineering aspect, as well as of the biomechanical aspects of arthroplasty, which will fail, which will succeed, and what are the reasons for that. So much of knowledge with him, and we have got so much to learn from him. Over to Mr. Martin Zimmerman. He is going to talk on the ceramic materials impact on immunology, trunnianosis, which is the buzzword, or ceramic, the answer. Over to Dr. Martin.
Okay, hopefully you can hear me.
Yeah, you're able to.
Okay, perfect. So let me share the screen, and hopefully it will work better than last time. Can you see the slide?
Yeah,
I can see on the side that seems to be working there.
It's working.
Okay, first of all, thank you for this very nice introduction about myself. Thank you. And thank you also for Deputy Johnson Johnson and the organizing committee to giving me the possibility to speak about, as I said, ceramic materials. We'll have two presentations, one about the impact on immunology and the other one about fretting and corrosion. So let me start with the first one. Oh. Voilà. So first of all, I have a disclaimer and general information about the product presented. And as mentioned before, I have a disclosure, very important, since I am a consultant for Ceramtech, the manufacturer of the Biolox ceramic components that I will present tonight. When you speak about immunology, I think that these slides make a nice summary what you want to achieve, as shown here on the right-hand side. When you speak about the interaction between the host and the material, and the left-hand side, what you would like to prevent, typically chronic inflammation, infection, and so on. From the patient perspective, what impacts the clinical outcome? We have to distinguish what we call the non-modifiable risk factors, like the gender, the age, the comorbidities of the patient, but some factors are modifiable, like obesity, smoking, and alcohol. From the treatment algorithm, what impacts the clinical outcome are typically the place of surgery, the number of the experience, let's say, of the surgeon, the type of anesthesia, and the type of surgical approach. But also, actually, the choice of the material can impact results or the outcome from the clinic. If you look now from more specifically about the bearing couple, of course, what we would like to have is a biocompatible material that we use, that we are wear resistance, scratch resistance. But tonight I will speak more specifically about the immunological response. We have to distinguish two aspects or two levels of response on a cellular level. First, what I call the bulk material, which is at the surface of the implant, and also the reaction from the host coming from the particles, typically after the wear or the usage of the implants. Here is described what you should achieve: tissue integration or encapsulation of the particle, or even particle removal. Let me start more specifically about the particles. Again, as a summary, what you need to achieve on the top in green: encapsulation, particle removal. What you would like to avoid, typically inflammation, osteolysis, metallosis, necrosis. If we speak about effect of the particle, of course, you are all aware that's the wear conditions, which is critical. This is now an in vitro study which performed with the most recent material used in arthroplasty, ceramic material against highly cross-linked polyethylene with vitamin E, and the same with cobalt chrome. On the left-hand side, what you call the ISO 14242 are the normal conditions when you do the wear testing. As you can see, thanks to the high properties and the good properties of the highly cross-linked polyethylene, there's no big difference of the wear between a ceramic head and a cobalt chrome head. But if you go, as here shown on the right-hand side, in what we call suboptimal situations, typically when you have bone cement particles or other particles coming in between the articulation, then you see that is a difference drastic about the wear conditions if you have the cobalt chrome and alkylic polyethylene components. Not only the polyethylene is wearing more, but also the cobalt chrome and all the problem dealing with the release of cobalt ions, cobalt particles in the body. So the reason why ceramic behaves better than cobalt chrome, I think it's also well known from everyone, is due to what we call the scratch resistance. And this is easily measured by having an indentation at the surface of the material. And we can demonstrate that the ceramic material, Biolox Delta particularly, is 10 times more scratch resistant than cobalt chrome. The question arises now, okay, we have much less particle with ceramic, but what is the impact of the ceramic particles in the body? And this has been done in the Leeds University, the impact of different material particles on the cytotoxic reaction of the body. And we can see at what we call really clinically relevant concentration for all ceramic kinds, the Biolox Delta and the Biolox Forte, there's no reactions occurring in the body that do not cause release of immune mediators like cytokine at the relevant concentration, which is not the case, as you can see, with cobalt chrome. So not only is important what type of material particles you have, but also the concentration. And that's exactly the problem with the cobalt chrome. Let me go now to another level, metallic ions. The metal ions can come either from the bulk of the material, but also, of course, from the particle from the wear debris. And again, as shown here, what you want to avoid is what you call metal hypersensitivity, or even in most cases, metal toxicity. To analyze that, we have done some study about the metal or the particle release from a cobalt chrome ball heads and compare that with a ceramic ball head. Some may ask the question, how is that possible to measure the release of chrome or cobalt ions from the ceramic? We have done that because there was many years ago some claims that due to the fact that you have chrome oxide in the ceramic to enhance the mechanical characteristic, this chrome oxide may release out of the bilux delta and create metallic particles. So to demonstrate that, we have done that testing with a beva and serum as a control, with cobalt chrome ball heads and ceramic ball heads, both the same size without any motion, and they are stayed 7 days at 37 degrees. And as you can see here, having a cobalt chrome ball head, we have a release of cobalt and as well as chromium particles, ions in the fluid, which was not the case with the ceramic. So I think we finally demonstrate that there is absolutely no risk to have any release of metallic ions from the ceramic ball heads. Let me speak now about the bulk material. And again, as I summarized on the top in green, what we would like to achieve, tissue integration, and what we want to avoid, chronic activation of immune cells leading to typical this kind of infection. So in order to analyze that, also some study has been done in vitro to measure what is the bacterial adhesion on the surface of different materials used in the orthopedic. As you can see here, two staph has been used, staph epidermidis on the left-hand side and staph aureus on the right-hand side. And in these two kind of bacteria, we can demonstrate that on the surface of the ceramic, bilux delta, bilux forte, we have statistically less formation of the biofilm and the reduced thickness of the biofilm at the surface of the ceramic, compared both to metal and to polyethylene. I think it is well known that the surface chemistry or the surface topography of a material influence the wettability of the material in vivo, which has the impact of the absorption of the protein, which enhance the protein absorption and reduce the formation of the biofilm. And we can demonstrate, thanks to this in vitro study, that at the surface of the bilux delta material, you have less formation of biofilm as compared to cobalt chrome. The question is now, okay, it's very nice what Martin Zimmerman tells us, but is everything in vitro? The question comes now, what is in the situation in vivo? Does these good characteristics of the bilux ceramics with regards on the surface activity also relate to in vivo results? I would like to concentrate, due to the time, specifically about periprosthetic joint infection, because I think this is more and more an important cause for revision of primary hip. You have to know that the presence of an implant material reduces the necessary bacterial concentration for an infection by a factor of 100,000. And as you can see here on the left-hand side, it has a lot of different causes which occurs. Last but not least, it decreases the medical cost by a factor 2 to 4 compared to the revisions with non-PGI. So I think it's an important complications that needs to be dealt. A publication from Bristol and published in the Lancet Journal has been analyzing what are the risk factors specifically for creating periprosthetic joint infection. Different factors have been investigated. Some patient factors, typically the gender, the age, the BMI, but also some factors related to the health system, the place of surgery, the operating surgeon volume, and some factor typical related to the surgery, osteoarthritis, fracture of the femoral net, but also the choice of the bearing type. As conclusion from this wide study, they realized that there's some factors which is well known, which are impacting the risk of PGI. Typically, the male sex are higher risk of PGI, younger age, which is astonishing compared to some other study, but what is well known, elevated BMI, diabetes have a higher risk for patients creating the PGI. But interestingly is that they also demonstrate by usage of metal bearings also increase the risk of PGI. This study is now summarized here about the use of the bearing materials. If you concentrate now at the 2 years results, you can demonstrate that compared to metal on polyethylene, which is served as a reference, by using a metal on metal or ceramic on metal, which actually does not exist anymore on the market, you have an increased risk of revision due to PGI. In contrary, by using ceramic on ceramic as well as ceramic on polyethylene, you have a lower risk of revision due to periprosthetic joint infection. Actually, this study is not the only one showing this kind of results. If you look at different important registries worldwide, if you look on the Medicare registry, which is from the USA, the NGR, which was just shown now, but also with the Italian registry, RIPO from Emilia-Romagna, the Australian registry, and as well as the New Zealand registry. All of them clearly demonstrate that there is a consensus by avoiding the usage of metallic components in the bearing, typically cobalt chrome, and by using ceramic, you are reducing the risk of having periprosthetic joint infection. One of possible explanation to that has been coming from this study from Dr. Trampus from the Charité Hospital in Berlin. He was analyzing with sonication based on explants taken from revisions for for patients, what is the quality if there is a biofilm at the surface, and if yes, how thick is this biofilm? So first is the qualitative assessment. That means in which situation you have the formation of the biofilm. So he came to the conclusion by extracting the metallic components. In 92% of the case, there was a biofilm at the surface. With the polyethylene components, in all the surface of polyethylene components, there was a biofilm, and only in 69% of the ceramic, there was a biofilm. But more interesting is what we call the quantitative assessment. If there is a biofilm, how thick is that biofilm? And this is measured in CFU, colony forming unit per milliliter. As you can see here, with both the metal and polyethylene, you have a colony forming unit higher than 5,800. And comparing for ceramic is very low. So not only there is less cases of explanted ceramic components with a biofilm on the surface, but if there is a biofilm, the biofilm is much thin than compared to metal and polyethylene. So this brings me to the conclusion of my first part of the presentation. We believe by using ceramic components, material matters in the view of clinical outcome. We have an excellent biological behavior of the ceramic. It's very unlikely pathogenic reactions to ceramic particles, the lowest wear of all bearing materials, highly scratch resistance articulating surface. It is associated with a lower risk of revision for PGI. It reduces the biofilm formation compared to other bearing materials. And this comes now to the end of my first presentation. I think we can have the questions at the end of the two presentations. Is that correct?
Yes, we'll go for the questions after the second presentation also.
Okay, yeah. So I continue. The second title of my presentation is about trigoniosis in total hip arthroplasty. Are ceramic heads the answer? Again, my disclaimer and specifically my disclosure as a consultant for CeramTech. If we speak about fretting and corrosion, we have to analyze and to identify two kinds of perspective. What we call first is the technical perspective. You can imagine that you have the damage of the taper due to the fretting corrosion is so high, so drastic that you can have fracture of the ball head at the surface of the taper. But this is very seldom. But more critical is what we call the biological perspective. And this is the effect of the corrosion products on the organism. When you speak about biological, we think about the production of metallic wear debris, corrosion products, metallic ion release, creating all this problematic of metallosis and ALTR as published widely in the last few years and as demonstrated with my presentation before. Looking at some recent publications, specifically with cause of revision due to fretting and corrosion, trigoniosis, we can see that based on different publications, you can have up to 4.2% of case of revision if you are using metal on polyethylene articulation. And this can go higher than 12% with metal on metal. But again, as you know now, metal on metal is something which is not used anymore. But still, with metal on polyethylene, you have to see that up to 4% of cause of revision can come for the effect of trigoniosis. Excuse me. So the question that we ask ourselves at CeramTech, can ceramics mitigate fretting and corrosion, knowing that the ceramic ball head is much harder than cobalt chrome, as I demonstrated before? So does it create more or less fretting corrosion at the surface of the taper of the stem? So we have done three questions. Is the qualitative corrosion on stems the same for total hip arthroplasty with ceramic and metallic heads? Second, what about the quantitative corrosion? If there is loss of material, where does it come from? From the taper of the stem or the taper of the ball head? And finally, I would like to speak also a few words about fretting and corrosion for what we call the sleeve ceramic with a Bilox option system. Let me start with the qualitative aspect. To do that, we have a study from Steve Course from America, which is based on a match cord study of 50 ceramic and 50 metallic retrieved head stem pairs They exclude metalling on metal, and they use the X score noted 1 to 4 as a qualitative assessment. What is this qualitative assessment? You can see that on the right-hand side. Score number 1, no fretting on corrosion, 2, mild fretting on corrosion, 3, moderate, and 4, severe. On the left-hand side in pink, we have now the results observed with the ceramic ball heads, and the right-hand side in blue with metallic heads. So you can see in general view that the pink is lower than the blue. So we have qualitatively, we observed less risk of fretting corrosion with ceramic head compared to metallic heads. Interesting is also within one family, if you are using ceramic heads, but depends now on the material of the stem. If you use the conventional titanium, aluminum, vanadium, compared to TMZDF, which is also called that beta titanium or flexible material, you also have a big difference. The conventional titanium creates less risk of fretting corrosion compared to the beta titanium. Let me go now to the second aspect. What about the quantitative results? Again, based on the study of sieve cords, we elaborate even more further the analysis of these explants. First, we analyze what happens on the taper of the stem. If you're using ceramic ball heads, there is some range of material loss, but much less than with cobalt chrome ball heads. So this is first a very interesting results. Knowing that ceramic is much harder than cobalt chrome ball heads, we could expect that we should be more damage on the taper, which is not the case. So it effectively not only a problem of mechanic or friction between two surfaces, but also a chemical reaction. That's why the reason we call that fretting corrosion reaction. So we have less damage on the stem taper. If you look now at the taper of the head, this is now the big difference. There's no material loss coming from the ceramic because it's so hard. There's no possibility from a titanium stem or cobalt chrome stem to abrade the surface of the taper of the ceramic. But in contrary, if you have a cobalt chrome head, then you have a big quantity of loss of material. And in this case, remember, the loss of material that you have with cobalt chrome creates typically this problem of chrome ions, chrome particles, or cobalt ions or cobalt particles in the body of your patient. So we demonstrate here that by having a ceramic component, you have much less material loss than having a cobalt chrome component. Let me go now to the last part of the analysis. What about the fretting corrosion in the case of the Bilox option system with the sleeve? For those who don't know exactly what it is, there's a small picture here. It is a ceramic ball head with a bit bigger taper and there's a sleeve which is used typically normally in case of revision. When you want to keep the stem in situ and the taper is damaged, then you put the sleeve to avoid to use a primary ceramic ball head directly on a damaged taper. So as you can imagine, before launching this product, Ceramtech has done a lot of testing in vitro and investigation showing about the fretting and corrosion, and the conclusion is that the use of a Bilox option adapter has no significant effect on the corrosion of a modular taper connections. But interesting is now about the retrieval studies. Unfortunately, there's not so many explants which is used because it is not so many cases that we use this Bilox option system. There's two main studies from Figi and McDonald, which is reduced limited time of implantation, but both came to the conclusion that at the interface head sleeve and sleeve stem, there's low levels of fretting and corrosion. And this is thanks to the fact that Ceramtech make the right choice of material. The sleeves are performed in the conventional titanium vanadium alloy and not in cobalt chrome or on this beta titanium. Here's some example. We see now the inside of the sleeve, that means which is in contact with the taper of the stem. We had some cases without any fretting corrosion, with minor fretting corrosion and moderate. And if you look at the external part of the sleeve, which means in contact with the ceramic, there was only cases of no fretting corrosion or minor fretting corrosion. There was no other one with level 3 or 4 observed with ceramic ball heads. This brings me also to the conclusion of my second part of the presentation of tonight. You have to know that fretting corrosion can be the reason of revisions up to 4.2%. Ceramic heads mitigate damage and material loss on the stem, taper, irrespectively of the same material. The material loss comes mainly from the taper of the head. And if you speak about cobalt chrome, you have a high magnitude of material loss and you are creating chrome and cobalt metallic debris in the body of your patient. Ceramic heads are resistant to corrosion, and the sleeve ceramic also reduce the risk of retting corrosion. This is the reason why, with more and more, if you look on the literature, recent literature, they recommend the usage of ceramic heads to avoid the adverse tissue reaction observed clinically with metal polyethylene. Thank you for your attention.
Thank you, Dr. Martin, for making a convincing argument for using more and more ceramic. So now the topic is open for discussion. Any questions? So you said that the incidence of PGI is decreased when we use ceramic in almost all registry studies. So
Yeah.
the bearing is one aspect, but the exposed stem and other things are also there. Was it studied that the biofilm layer must be formed in that, if at all, if there is anything? So can it be explained?
Yeah, that's a bit, for the moment, difficult to explain. But as you know, one of the worldwide reference for periprosthetic joint infection, Dr. Parvizi, just recently again make a publication analyzing his patient and came to the conclusion that effectively by actually if you want exactly to tell the sentence correctly, is by avoiding metallic components that you are reducing the risk of PGI. And the solution is because beside cobalt chrome, we have only ceramic as a good solution. So by having ceramic, you increase in favor to reduce the risk of PGI. But one of the possible explanations, as we said, is the surface of the ceramic, which is reducing the risk of biofilm formation. And we believe that's the reason. I'm not sure if you answer exactly your question.
Yeah. It is difficult to explain because the other exposed metal surface will be there for the biofilm formation, and how it is not formed there, but the evidence is there to see that if we use a ceramic bearing, that the PGI is definitely decreased, because it is across all the registries it is found.
Yeah.
And second question is that what is the maximum follow-up of using a taper sleeve and the retrieved specimens, whatever which has been retrieved?
Yeah, we have the sleeves now since 2000 already. I'm not more sure if it's 2008 or 2002. So it's more than 12 years that we have this Biolox option system worldwide.
And the study which was done, which was studied about all the corrosions, what is the maximum period which was studied? Because
with the retrieved one?
Yeah, the retrieved ones.
That's just a few years. It was, I think the longest was 4 or 5 years in vivo.
Okay. So probably
that's not long enough.
Yeah.
The point is that often this case is difficult to find also again the retrieval because it's already a revision. And the few cases they got was also due to infection. So it was the reason at that moment they get this case of revision of components.
Yeah. So thank you so much. So if there are no further questions, we thank once again for all those wonderful enlightening lecture about ceramic. Thank you.
It's always my pleasure. And I really hope that soon I can come and be live with you in India because I love to be there.
Yeah, thank you. Thank you once again.
Okay, thank you. Good evening, everyone.
Thank you. So with that, we come to the next topic. So now we'll go to the routine, and once we have decided to do, we have to know about the approaches. For that, I request Professor Tirunarayanan to deal about approaches, different approaches for THR.
Good evening to everybody. I mean, at the outset, I would like to thank my teacher, Professor Singadival Saru, for having invited me for this instructional course lecture of OASIS. And I also thank the OASIS and TNOI Con for organizing this program. Change பண்ண முடியாதா? இது சொல்லுங்க. Okay, thank you. So basically about the approach to hip. I think the hip is the most exposed joint, and an ideal approach, of course, should be very safe. The exposure should be very adequate. There should be minimal soft tissue damage. Neurovascular structure should be preserved as much as possible, and it should give you the least complications. So the problem now comes with hip, because there are a lot of approaches which are available, and to go to which approach. So I also got confused how to approach this topic. So I structured my talk, and going into the approaches, then I realized that a lot of history is there. The history was very fascinating. So I thought I'll just give a brief hint of the gist of the history, whatever is there, how this approaches evolved. And of course, a little bit of procedure illustrations, because these approaches are, very difficult to teach. So because it has to be learned, it has to be practiced, you have to do it again and again. So just one lecture cannot give you all the information in this approach. So I've reduced that much of surgical approach, the surgical illustrations I've reduced as much as possible. And I've analyzed advantages and disadvantages of each of the approach. And I've just tried my best in a very unbiased manner of reviewing more than 50 articles by the Cochrane, Embase, PubMed, and Google databases, and to find out if there is a best approach. So the approach, if you want to start, I think a trochanteric osteotomy cannot be forgotten, because it was started by John Charnley, the hero of THR. I think he himself did the trochanteric osteotomy, and this was the trochanteric osteotomy. These pictures were from the original Charnley's articles. So you can see, you can see the trochanteric osteotomy was done in this plane. He did it in a coronal plane, and he distalized the trochanters. So once the trochanteric osteotomy was done, the short external rotators along with the trochanter was also incised, and the head was dislocated posteriorly. And there was some biomechanical advantages. The trochanteric distalization reduced the shear forces on the implant. So it was a low friction arthroplasty, and the longevity of implants were there. The abductor pull was definitely enhanced because of distalization, and this abductor tension reduced the risk of hip dislocation. So biomechanically, it was a very stable joint. So its success rate was very high, and nearly the success was around 25 to 40 years. 85% of the implants were stable for nearly 25 to 40 years. And there, of course, disadvantages were there. And Frenkel et al. Study in 1993, where he showed 15% of non-union of Charnley's hips. So this non-union, of course, led on to pain, limp, the higher incidence, trochanteric bursitis, and heterotropic ossification of all the approaches in trochanteric osteotomy was the highest. And of course, there are a lot of modifications came up. The Harris osteotomy, he osteotomized 1 centimeter distal to where the Charnley did the osteotomy, and he did not distalize. And this was the Harris osteotomy. Here again, you can see the hip is dislocated posteriorly after the short external rotators. The short external rotators also incised after the osteotomy, and the hip is dislocated posteriorly. And next was the lateral approach. Of course, there's not much history about lateral approach. There are two important approaches: the McFarland-Osborne approach and the Hardinge approach. The Hardinge, he gave the approach in 1982, and for more than 40 years, the approach is still being used so widely. And McFarland and Osborne, so this was the actual, so what they did was the entire sleeve of gluteus medius, from the posterior edge of the gluteus medius, they just took it as a sleeve from the trochanter along the vastus lateralis, shifted it anteriorly, and then you can see the gluteus minimus there, which is right underneath. So next, the gluteus minimus and the capsule was incised, and the head was dislocated. So this led on to a lot of abductor problem, because the entire abductor was released. Of course, the abductor limp was there, and abductor weakness was very high. So it was slightly modified by Hardinge in 1982. This was the article which he published in 1982. So what Hardinge did was, here you can see, Hardinge took the anterior 1/3 of the gluteus medius along with the conjoint tendon of vastus lateralis. So he incised the anterior 1/3, keeping behind the posterior 2/3 of the gluteus medius intact. And then after incision of gluteus medius along with the vastus lateralis, he was able to see, this was the original article of Hardinge. So this picture was there in the original Hardinge's article. So after that, you can see the capsule. Then, of course, once you incise the capsule, you can go into the, you can osteotomize the neck, and you can deliver the head outside. So this was about the lateral approach. Posterior approach has got quite a lot of history. In 1874, it was described by Langenbach, of course, the Cocker-Langenbach approach, everybody knows, for acetabulum. So in 1874, he initially used it for femoral head resection in suppurative arthritis. So Theodore Theodor Cocker was his apprentice, apprentice of Langenbach. In 1907, he extended the incision caudally. Initially, when Langenbach started the incision, it was only the horizontal incision. So, Cocker extended it caudally, and he incised the short external rotators, and he was able to get more exposure. So then Gibson started his approach. What Gibson did was he went slightly anterior, and the entire gluteus maximus was, he did not split the gluteus maximus. The entire gluteus maximus was shifted posteriorly. And of course, in 1957, Moore's article, one of the most popular approaches till date, 1957, it was published. And then some modifications by Horwitz and Marcy, where the minimally invasive approaches came in. So this is a posterior approach. This again, I've not added color pictures because these are the pictures which came from the original articles of Moore. So it wasn't much different from the color. Of course, except for the black and white, all the details are here. So here you can see the incision. So what happened was, when Gibson started, the incision was slightly anterior like that. Though it was posterior incision, slowly the incision started going back little more and more posterior. So that is why it is called a southern approach. So that is what was written in the article, but few say it was done in the southern part of Europe, or for UK. But actually in the article, what it has been mentioned is, here you can see the, gluteus medius maximus here. You see, it went more posterior, and now it's called southern approach. So the incision, of course, everybody knows, the posterior third of the trochanter is taken as a base, and then along the shaft of the femur, and then you extend it proximally, just 10 centimeter proximal to the posterior superior iliac spine. And now once the incision is made, the dislocation you can see here, it is flexed, adducted, and internally rotated for the head to be delivered out posteriorly. So the short external rotators can be visualized very clearly. The gluteus maximus is split. In the idea of splitting the gluteus maximus was, it was split into anterior and the posterior halves. The anterior half, the superior gluteal nerve and the superior gluteal vessels were protected by the muscle. The inferior half, the inferior gluteal nerve and inferior gluteal nerve muscles were protected. So both the superior gluteal nerve and inferior gluteal nerve were very safe by splitting the gluteus maximus along the line of incision. So after that, the short external rotators are incised. They are incised very close to the trochanter because of the sciatic nerve, which is, you can see the sciatic nerve here. The incision is made very close to the trochanter with the 5 mm sleeve, 5 mm away from the trochanter, so that you can suture it back. So these were the original instruments that was used by Moore himself. And here you can see, I just mentioned about the split along the line of gluteus maximus to prevent the injury to superior gluteal nerve and inferior gluteal nerve. And here again, you can see the short external rotators, which is incised very close to the trochanter. And now, of course, posterior approach, I will mention it later. The piriform sparing approach, the capsular preservation approach, and so many approaches have come to minimize the complications and to minimize the dislocation. So anterior approach, of course, it was used even before. In 1880, it was published by Hutter in 1882. Then he used a vertical approach. It's very, very similar to Smith-Peterson approach, but it is only the vertical component of the Smith-Peterson approach. And then, of course, Smith-Peterson himself, in 1917, he started the approach. It was published in 1917. And in another article, it was published in 1949, where the hips that the arthroplasties that he had done by anterior approach was published. And of course, the Smith-Peterson approach, the base of all the anterior approaches, with lot of modifications, lot of changes have come in anterior approach, but the base of the anterior approach is still the Smith-Peterson approach. Here you can see it is done in supine position, and the incision, of course, everybody knows, it is along. And then once you make the incision, the one structure which has to be preserved is the lateral femoral cutaneous nerve. And then once fascia lata is incised, fascia over the sartorius is incised, you get the plane between the sartorius and tensor fascia lata. So the next step is just separate the sartorius and tensor fascia lata. You'll go into the rectus femoris tendon. So this rectus femoris tendon, the reflected head of the rectus femoris tendon is attached to the acetabular lip and the anterior inferior iliac spine. But here, the one important structure is the ascending branch of the lateral circumflex femoral artery that you have to cauterize, or you'll have to preserve that. So once the rectus femoris is incised, you can go into the anterior capsule, and then the anterior capsule is incised. But here, sometimes to get adequate exposure, what he did was, in the iliac crest, the three muscles getting attached to the tensor fasciae lata, gluteus medius and gluteus minimus. So he erased all those muscles and he was able to get wider exposure. So all the modifications of the anterior approach are many. And of course, Jude brothers, they popular in pelvic and acetabular fractures again. They did a lot of study. They did this Smith-Peterson approach. In fact, Smith-Peterson approach was popularized by Jude brothers. And then another landmark article came in 2003, but it was started in 1980 by the senior Kegi. So Kegi, the Kristaps Kegi was the senior one, and the RM Kegi was the the junior one. So they did more than 3,000 cases. They published an article in 2003 where more than 3,000 cases were analyzed, all done in anterior approach. So the importance was they did mini incision technique and they used some specialized instruments, and they did not use any specialized table, because the anterior approach which is being done a lot of specialized tables are required, but Kegi did all in flat top tables. So this was the position of the patient. You can see it in supine. The other limb was kept in complete abduction so that this limb can be brought into adduction for femoral reaming. So here you can see, so this was the standard incision, the vertical incision of the Smith-Peterson or the Hutter incision, and specialized instruments was used to ream the femur. See, these are the curved ones which go inside easily. And if in case of obese patients, see here you can see the acetabular reamer. They've made another small incision here to insert the acetabular reamer. And when in obese patients, also for femoral reaming, an incision was made proximally and this femoral reamers were inserted. And of course, the most important person of the anterior approach was Joel Mata. So his paper came in 2005 in CORR. So he used a specialized table called the ProFX table of Mata. So here you can see the specialized table, something like a fracture table, where the limb can be kept in any position. And of course, there was a clamp here. You can see a hook. So once this femur is delivered, the femur was just, it was attached to this hook for him to ream easily. So the number of assistants he was able to reduce by using this hook. So the femur, when they want to ream the femur, it has to be kept in a lot of extension. It has to be kept in hyperextension in an anterior approach. So he was able to keep in hyperextension. He was able to externally rotate. So it has to be externally rotated and adducted. So only then in an anterior approach, you can ream the femur. So this table was used, and now it's being used in a lot of other centers where the anterior approach is being used. And you definitely need a C-arm control for you to place the cup and also to ream the femur. It is always better to use a C-arm control in anterior approach. And other approaches are there, which I've just mentioned, the Watson-Jones, the anterolateral approach, another one popular approach, and two incision, minimally invasive approach, minimally invasive posterior, medial approach, etc., and the list goes on and goes on. So after seeing all these approaches, so now we have more confusion. So which approach is best? So in analyzing which approach is best, I just took the following surrogates. So early functional recovery, amount of muscle damage in each approach, whether the amount of dislocation, wound complications, and nerve complications. So these are the 5 parameters which I took to analyze which probably is the better approach. So early functional recovery was analyzed based on time up and go test. This test is when after the surgery, how early the patient started walking. Gait speed, so that is the cadence of the gait, mean steps per day in 2 weeks time. So what is the number of steps the patient is able to walk 2 weeks after surgery? Narcotic use, of course. When did the patient discontinue walker, and when did the patient discontinue all the aids, all his walking aids after the surgery, and pain scores and hip scores? So analyzing that, Taunton et al. Published an article. There are many articles were there. This one good article was there. So he compared anterior approach and posterior approach. In anterior approach, the time to discontinue walker was on a mean of 10, whereas in posterior approach it was 15 days. And time to discontinue all the gaits in anterior approach was 17 days, whereas in posterior approach it was 24 days. And mean steps per day at 2 weeks, the mean was 3,000, around 4,000 steps in anterior approach and around 2,250 steps in posterior approach. So, and clinical pain scores equalized in anterior, lateral, and posterior approach within 3 months. So final analysis, early recovery is definitely seen in anterior approach. but they all equalize in 6 weeks time. And midterm and long-term recovery, absolutely there is no difference at all. And next is the muscle damage. The muscle damage by each approach, because we split the muscle, we erase muscle. So what is the amount of muscle damage that happens? So that was analyzed based on biochemical studies, that is inflammatory markers like interleukin, cytokines, and creatine kinase. And MRI was done to find out the amount of muscle edema and the fat atrophy that happens. And a lot of cadaveric studies also have been done, and combination studies are there. So here you can see between anterior approach and posterior minimally invasive approach. So the creatine kinase immediately after the first postoperative day, I mean on the day of surgery, postoperative day 1, 2, and a cumulative amount of creatine kinase. There's definitely a difference in the direct anterior approach. The creatine kinase levels are lesser than even a minimally invasive posterior approach. So the results, the inflammatory markers were high up to 4 days. Lateral, oh, sorry. I think I've gone back. Sorry. The results, yeah. Here you can see the inflammatory markers high up to 4 days. Lateral approach, the inflammatory markers were very high, higher than posterior, which is higher than anterior. But they all equalized in 1 month time. And MRI based, the MRI was done in 0, 3 months, and 6 months. But even up to 6 months in lateral approach, they've seen that fat atrophy and muscle atrophy are still persistent even after 6 months in MRI. And muscle damage finally is lesser in anterior, highest in lateral. And another most important complication any surgeon fears is dislocation, because dislocation is one of the most difficult things for the patient as well as the surgeon. So these are the various studies. 1984, Vicar and Coleman's study showed 10% dislocation in posterior approach. In 2001, it was 3.23%, which is again 6 times more than lateral approach. But this was about 13,000 cases. It was a meta-analysis of 13,000 cases, which showed 6 times higher rate in posterior than lateral. But after 2001, a lot of studies have shown that only 1% of dislocation in posterior approach, and again lateral is even lesser than 1%. So we'll just analyze what is the reason for that. And direct anterior approach, a lot of studies have been shown. So revision for direct anterior approach after dislocation is much lesser than 1%. So what actually happens when we analyze, the lateral approach gave the least dislocation rate. Anterior approach also, the dislocation rates were lower. But posterior approach, higher dislocation rates were seen in studies before 2001. But after 2001, the dislocation rates are around 1 to 1.2%. The reason being that after 2000, the large sized heads came, 36 size head came. So the usage of large size head, posterior capsular repair. Initially, posterior capsules were not repaired. Posterior capsular repair, short externals were reattached in a proper manner. And sometimes the piriformis preserving approach, all these aspects were added on to the posterior approach, and the dislocation rates were much lesser. Of course, these are all these studies showed that lateral approach is dislocation is lesser, but posterior approach is not too high, definitely. And periprosthetic and joint infections, of course, we had a huge discussion about periprosthetic joint infection regarding metal and ceramic. But what happens with respect to approach? So with respect to approach, you can see the Ilsman et al. Who published in 2016, so showed 400 direct lateral and 700 direct anterior approach. The periprosthetic joint infections in anterior approach was 2.3%, whereas it is only 1.7% in lateral approach. But the most important factor was in anterior approach, the gram-negative infections were 35% of the 2.3%. The gram-negative infections were 35%, which is very difficult to treat. Whereas in the lateral group, the gram-negative infections were almost nil. It was 0. So, and another one factor is when the BMI of the patient is very high. Normally in anterior approach, the higher BMI, normally they don't take up for surgery. So, but in this study, the anterior approach, the BMI was very low. But in spite of that, the infection was 2.3%. And there are 2 studies of Purcell et al. One was in 2016, where he studied on periprosthetic joint infections on anterior approach, which showed that when the BMI was more than 35, the infection rate is 2.5%, whereas when the BMI is less than 35, the infection rate is only 0.35%. In 2018, he studied around 2,000 patients of both anterior approach and posterior approach.
he came to a conclusion that there were not much difference between the joint infection in anterior and posterior groups, but the wound complications were higher. So periprosthetic joint infections were not that much, but wound complications were higher in anterior approach. So what possibly could be the reason in anterior approach? The infection and the wound complications are higher. So the problem is it is very close in proximity to the perineum and the anterior abdominal folds. So especially in obese patients, the infection because of the skin folds and very close to the perineum, especially in obese, is found to be the reason why in anterior approach, the joint infections and wound complications are higher. And of course, nerve injury in anterior approach, very high incidence of lateral femorocutaneous nerve involvement. It's usually neuropraxia which resolves. And in direct lateral approach, the superior gluteal nerve is at risk because you should not go more than 5 centimeters above the tip of trochanter. The superior gluteal nerve can get injured. Already the abductor is compromised. So if you go more than 5 centimeters, the every chance that superior gluteal nerve also might get injured or go for a neuropraxia, and the abductor mechanism does not work for very long time till it recovers. And in anterior approach, sometimes the femoral nerve, it's quite rare, but the femoral nerve also can get stretched and get injured. And of course, sciatic nerve, the incidence is 0.1 to around 1 point. Different studies are there which shows 0.1 to 1.5% involvement of sciatic nerve in posterior approach. So the evidence-based observations. So the anterior approach has slight advantage when it comes to early recovery and degree of muscle damage. Infection is a problem with all approaches, but wound complications and infection rates are slightly higher in anterior approach. The lateral approach seems to provide the maximum, most stability. Abductor weakness is highest in lateral, minimal in anterior and posterior. And dislocation rates are comparatively higher, though not very high in the recent times, comparatively higher than lateral. So, and one more thing is the abductor weakness, though in posterior and anterior, we don't touch the abductor, still studies are proven that abductor weakness is slightly there. Because one group of muscle and hip, when they are incised, the other group, like the abductor, also gets involved, but not to the extent what happens in the lateral approach. So, in conclusion, the choice of surgical exposure is based on, so what approach you want to choose is based on good knowledge of the anatomic basis of each approach. As few specific indication warrant specific approach. Something like when the hips are ankylosed and the knee are ankylosed, you want to do a hip, you will not get any flexion. So that time you cannot go and do a posterior approach. So if it is an acetabular fracture, plate is kept posterior, you want to remove the plate and then you want to do a THR, that time you cannot go anterior or that time you cannot go lateral. So that time you have to go posterior. So in very highly obese patient and the BMI is very high, you cannot persist to go in anterior approach. That is always safer to go in the lateral or posterior approach. And of course, each approach has got its unique advantages and disadvantages, which you have to understand. And above all, surgeon's experience and skill makes all the difference. In practice, though we talk about all the approach, which approach is good or which approach is not good. So each approach is like a religion to each surgeon rather than science. So, contradicting religion will be a huge crime here. So I don't want to do that. And just a few message to a lot of youngsters are here. So I just want to pass on a little bit of message to the youngsters. Thorough 3D orientation of hip anatomy is absolutely essential for youngsters. Try to master one approach. You keep on doing one approach, try to master one approach, but the alternate approach, you should always be ready. So it's not that you should not know the alternate approach at all. You should know to do the second approach, which will definitely come in handy. Attend more courses in cadaveric courses, life surgery courses, and visual medial tools like YouTube. A lot of surgeries are there. Definitely it is useful. And just go into a little bit of history of all these approaches. You will get a lot of information. It's very fascinating. Assess more cases and grab any opportunity to operate. So these are my references, which I want to just show. So I think that I just conclude my speech. And of course, I know it's a very controversial topic. Sir will shoot me if I say, posterior approach. And a lot of guns are pointing at me before, the starting of talk. So I hope I don't end up in the firing zone. Yes, sir.
Thank you, Dr. Thiru, for bringing out a lot of history into this approaches and making it very interesting. I really appreciate it, and bringing out the evidences of complications from being a routine talk. Thank you for that. So any questions? Anything? So If there are no any other further questions, since we are already running late, I thank you.
Thank you,
And
sir.
I request Professor Govardhan to hand over a small memento to Dr. Trochanter. Now, next, now I invite Dr. Rajkumar to talk about implant options in THR. He wanted to come here, but because of some development, he could not make it. So he is going to present online. Over to Dr. Rajkumar for presenting implant options in total hip replacement. Over to Dr. Raj.
Good evening to everyone. Am I audible?
Yeah, you're audible.
Thank you. Good evening to everyone, and I would like to thank Professor Singarodulu sir for inviting me and giving the opportunity. And sorry I couldn't make it because I was thinking that it is both hybrid and this thing, and due to this COVID situation also. So I would like to start the topic straight away. The implants options in total hip replacement. It's even though it's quite a wide topic, and both the acetabulum and the femoral sides are involved in that. I have tried my best to concise it and make it very, very simple and basic, very, very basic, since the topic and the whole talk is on basics in total hip arthroplasty. So everyone here will know father of hip replacement, Sir John Chanley, who developed the low friction arthroplasty. 33 years of survival of a cemented total hip replacement. Excellent result. This he has achieved with just a 22.2 mm metal head, unadulterated, non-cross-linked poly. Nowadays we have highly cross-linked, but those days no cross-linked at all. Primitive cementing, no third generation or no cement guns. And the bearing surface was a simple metal.
Sorry for disturbing you. I think you have not started sharing your screen.
Oh,
yeah.
Oh, sorry, sir.
We are not able to see the slides. Yeah, now we are able to see.
Oh, sorry. Okay. Quickly, Sir John Chanley, father of hip replacement, who developed the low friction arthroplasty. 33 years of survival, cemented arthroplasty with this with simple metal on poly bearing surface. 22.2 mm metal head, non-cross-linked polyethylene with the primitive cementing, no cement gun at all. So with that minimal availability, he has achieved excellent result, and now he is regarded still in all our talks. We are quoting for Sir John Chanley. So he was able to achieve this with only limited availability. But now, are we able to achieve the same thing? No, because there are too many choices to choose from. So we are spoiled for choices. Too many to choose from. This many implants are available. So much of designs, so much of modularity, but still we don't know what to choose. And this many owners who are producing these implants. So to go to which company, that also is there. So to select the implant options in total hip replacement, when there are so many options available, 1, 2, 3, 4, 5, 6, 7. So we are so much confused. Let us see here and try to come to some sort of conclusion. Total hip replacement, everybody knows that nowadays it comes to our mind, uncemented total hip replacement is the choice. Everybody tries to do that and learn that. But if you remember that cemented hip replacement, now even with so much of popularity of uncemented, cemented hip replacements are being done everywhere. And also people are trying to learn that also. So cemented hip replacement is the next choice. Then comes the hybrid and the reverse hybrid. So these are the 4 options available for us to do a total hip replacement. So which one to do that? In fact, to make it very simple, we can do anything we want. The only thing is it has to be done properly. Uncemented, cemented, hybrid, reverse hybrid can be done for any patient, but it is the surgeon's choice. So to look at it, as I told you, the uncemented is the most commonly done, and wide popularity is gaining, and a lot of numbers are going up in uncemented total hip replacement. But if you look at the National Joint Registry published just 1 year back, this report says the uncemented and the cemented are out. Even though the numbers of uncemented is more, it is plateaued out. The cemented also is gaining popularity. But if you look at that, interesting factor is the hybrid total hip replacement, the numbers are going up. So this keeps changing. Why this keeps changing? Because of the designs of the implants keeps changing, and the results also keeps changing. So at present, very surprisingly, the hybrid total hip replacement is the one being done more in UK. So this article very recently published in 2017, it says that THR after the age of 70 years, the risk of revision surgery is only 5%, whereas if it is done below 70 years, the risk of revision surgery is 35%. So how to go about this? But when we look at the indications for surgery, we have to be very careful, and patient selection is very, very important to avoid a revision surgery. So in that article, they have concluded that THR in less than 70 years, better to do an uncemented, and THR more than 70 years, better to do a cemented. It's a rough idea. It is not, we should not go very much fixed toward that. Why? I will come to that in a later in my talk. Cementless fixation, everybody will accept that it's the most, the outcome of this cementless fixation, that is an uncemented THR, is based on the osteointegration. The better the osteointegration, the outcome is good. And for that good outcome, we need a very, very less micro motion. So that is, what is that? Adequate osseous contact and firm fixation. The stability should be good. Whenever there is a very low micro motion, the bone formation is good. Whereas if the micro motion is more, the fibrous tissue and aseptic loosening happens. So what are the factors impacting this osteointegration? It is the implant design, very, very important. The implant design, appropriate surface treatment, that is a coating, mechanical stability, that is a surgeon's technique. And also then comes the patient's factor, that is the patient's bone quality. All these 4 factors contributes to the total outcome. So your best option, which implant? The implant that handles all the above factors is the one which you should select. Coming to the uncemented cups, this is the latest 3rd generation hemispherical cups which we are using now. That is the uncemented hemispherical cups is the go-to cups, and it is the 3rd generation where the you can use a neutral polyethylene, and wide variety of shapes and sizes of polyethylene can be used, and the highly cross-linked polyethylene, and also a lot of modularity, whether a cluster hole or a multi-hole. In a revision scenario also, it gives very good option. So to conclude here, the 3rd generation hemispherical cup is the choice. So to make it a little more very understanding for the youngsters, what is this hemispherical cup? It is if you take an example of a Depew Durlock and the Depew Pinnacle cups, the Pinnacle cup is a fully hemispherical cup, that is 180 degrees. And here the cup is quite deep, and it takes the neutral polyliner. Whereas in a Durlock, Depew Durlock, it is a sub-hemispherical, that is the cup is shallow, it is not very deep. So you have to keep in mind, you have to know the cup size design, because the reaming also matters according to the design of the cup. So for a hemispherical, it is different, and it is for a shallow cup, it is different. And in a shallow cup, the liner is, you have to use a lipped liner. So all these information you need to know, and the coating is also very, very important. The most common coating where we use is the titanium beads, where the titanium beads increases the porosity, but the more porosity is done by the tantalum cups and the gription coatings. So the coating also important. So the most highly porous cups are the trabecular metal cups and the gription cups, which helps in revision scenario and in osteoporotic situation. For example, the 3rd generation hemispherical cups, I've taken this as an example in a Depew company. If you see the Pinnacle cup with the porocoat, that is the basic coating. That is, what is that porocoat? It is a titanium sintered beads which is coated over the titanium shell, and this coating enhances bone integration, osteointegration into that, over that cup and into that. So the porosity is little less in this one, but whenever you want an more stable fixation, more adequate fixation, then you need to go for a gription coating over the Pinnacle cup. That is more commonly used in revision and in osteoporosis situation, where the 63% of the porosity. But for all these cups, the reamer, the trial, the original cup, all are 180 degrees. So that is most important. So you should know the instruments also before going in for these kind of cups. So for example, if you look at this, I'm in all this next few examples are going to be concentrated purely on the acetabular side. So 20-year-old post-traumatic arthritis. So our thought process is definitely a uncemented cup because he is 20 years old, male, post-traumatic situation. Yes, obviously you can uncemented hemispherical cup. The key point here is we should not try to over-ream and try to get a bigger head size. So whatever the acetabular, native acetabular size is, we should go for that appropriate size that you can achieve by templating, which Dr. the previous speaker very nicely explained about how to template. So this is an uncemented hemispherical cup. So here, what is that? A postseptic sequelation, very shallow acetabulum. Already, you can see there is no acetabulum at all. So in this situation, after you template, you need to know where you are going to place the cup, how you are going to achieve the stability. So here I have used the smallest cup, little high hip center. What is that smallest cup? In this, again in DePuy, you call it as the bantam cups, where the sizes starts from 38 to 46. The most important thing is 38, 40, 42. These three cups will take only 22.2 mm head. So that also you should know. So to know this, you need to template that and you to arrange, because always you will not have this bantam cups available in the shelf. So 38 mm cup is the cup which I have used here, and you have to arrange it before itself. So even though this is also an hemispherical cup, the cup coating is a porocoat coating, but the thing is, it takes only a 22.2 mm head. Next is a 40-year male, arthritis of both hips, secondary to DDH. The femoral side, yes, modular stem, but the acetabular side, you can get away with the regular uncemented hemispherical cups. 60-year-old male, again, uncemented cup, hemispherical. That should be the cup and go-to cup, and there should not be any hesitation at all. The company, you can select whatever you want. The coating, yes, but the hemispherical cup is the choice. 79-year-old female, yes, biggest debate. 17-year-old female, what cup to use? You can use here. The point here is you can use both, whether the cemented cup or an uncemented. It depends upon the surgeon, perioperative bone quality, and the stability you achieve. So I have used an uncemented cup with 2 screws for added stability. 74-year female, again, you can use both cemented and uncemented, but I have used an uncemented hemispherical cup. But if you look at the size of the cup, no need to go for a bigger cup. The correct size should be the key point here. So if you look at the literature, and over the period of time, so much of literature has published that the uncemented cups are the most preferred cups. But there are some contrary to that also. What is that? Here, look at this 73-year-old female, osteoporotic. I have used an uncemented cup. Why here? Because female patients, small acetabulum, most of the time, and these kind of patient not mobilized for a longer period of time, the bone acetabulum will be very soft, and do not hesitate to use a cemented cup. Yes, a lot of debates will be there. Better to use an uncemented in the acetabulum. It is not like that. If it is an old age patient, less active patients, females, small bones, better to use a cemented cups also. Again, one more example, 80-year-old female, the acetabulum. Look at the osteoporotic acetabulum on the right side. So I have used a cemented total hip replacement. 69-year-old female, multiple surgeries she has underwent. A trochanteric fixation that failed, that was removed. And again, this, look at the acetabulum, so smaller. So here I have used a reverse hybrid. The small acetabulum cemented cup was used, and for the distal loading stem for the femoral side. So in cemented THR, again, the National Joint Registry, if you look at it, recently published, the metal on poly, in a cemented THR, if a patient undergoes a cemented THR there, the most preferred is a metal on poly, invariable to the age. That's what they have published. So metal on poly still gives good results in a cemented THR, particularly in old age patients. So we have to keep that in mind. So in old age, less active, what is the message here? No need of any ceramic on ceramic or oxynium or any fancy implants. Just a simple time-tested metal on poly should be the choice for us to go for, and very, very important. So dual mobility cup, lot of, again, so much of noise about this dual mobility, whether to use that for routinely, that we don't know, but dual mobility articulation will not avoid dislocation. It will only lower the risk of instability. Keep it in mind, the indications are very, very strict. Neuromuscular diseases like post-polio or a hemiplegia is definitely an indicated one, but in a primary THR, it is controversial. Some surgeons routinely use, but mainly it is not needed. But predominantly it can be used in a tumor resection situation, and revision THR, yes, it has got a very good role in dual mobility cups. One example of 66-year-old female, non-epileptic on medications, secondary arthritis, I have used a dual mobility cup, which is definitely an added advantage. So dual mobility cup in a neck of femur, there are reports which says better to use because of the dislocation rates more are there, but still we don't know. We don't have long-term results. One example of a neck of femur fracture undergoing a dual mobility system. It's an uncemented dual mobility, but nowadays cemented dual mobility is also available, but try to avoid that cemented dual mobility system as of now, because those reports are not very good. Outcomes of dual mobility in a total hip replacement, the still high quality prospective studies are not there. So because of the too much of modularity, we have to be very careful. And if it is really indicated, we can use a dual mobility cup. Recently in 2016, this has been published that elevated serum cobalt and chromium levels in dual mobility cup systems with the fretting corrosion. So you have to be very, very careful. And this article recommends that you have to use dual mobility only in patients at high risk for dislocation. Otherwise, try to avoid that. So there are no currently available level 1 publications to support the or claim the advantage or disadvantage of that use. So this is about this cup side. That is definitely you can select whichever you want, but still cemented also plays a very good role. Coming to the uncemented stems. Again, in the first talk, the templating, it was very clearly explained about all the offsets and the center of rotation. In any stem, uncemented or cemented, but particularly in an uncemented stem, the medial offset and the neck shaft angle plays a very important role. So that also varies from company to company and design to design. So you have to be very careful and know the system very well. And if the angle, neck shaft angle varies, that also alters the vertical height and the medial offset. So you have to be very careful and know the system properly. To quickly simplify the classification of this uncemented system, always there are 6 types of uncemented stems. That is, the type 1 is a single wedge process. What is that single wedge process? It's a proximally coated, highly porous, proximally coated porous stems, which are only single wedges there, and it is medial to lateral. The plane is medial to lateral, and in the AP plane it is flat and thin. So the preparation here, it doesn't need any reaming. So it is very important. The stem is also short. It is a very, very good stems. And one example is the oculatum 2. And here only the broaching is necessary. So the next is the type 2. This is also commonly used. What is that? It is a double wedge, also called as a metaphyseal filling, because the majority of the metaphysis is filled with this proximal coated stem. Distal portion may be tapered or rounded. The most commonly used is the Smith & Nephew synergy stem and the summit, diffuse summit stem. Excellent stem, very good stability is achieved. The only problem here is the stem is quite long, and in revisions it is very, very difficult to remove this stem. So the bone loss happens more when compared to the type 1 stem. So you have to be very careful before selecting these things. You have to keep it in mind. The preparation involves distal femoral reaming and proximal broaching. So the third one is the third type is the 3 subdivided into 3. That is the tapered round, tapered cone, and the tapered rectangle. Nowadays, the most commonly used is the tapered cone. That is the Wagner cone processes. The round is the Mallory head system by Zimmer Biomed, and the tapered rectangle is the Zoy-Muller stem, the CLS stem. Again, these usages have come down, whereas the type 1 and type 2 usages are more. Type 4 is cylindrically coated, fully coated stems like the solution stem. Again, these are cobalt chrome stems. Nowadays, it is going out of popular usage very drastically because of the advantages with the distal loading titanium stems. So this is a type 4 stems. Type 5, very widely used in modular systems, like in the dysplastic situations. This is the SROM modular system. It has got a lot of modularity, but gives the advantage of getting the rotation version correct. So that is also very good. It is both in primary and revisions are available. Type 6, the curved and anatomical stems, fit and fill, very short stems, but the results are not that great, not widely used. Again, here everybody will know about this classification, DORS classification. It has been used in many centers, validated, tried, debated. Whether it is always reliable, it is not always reliable. But having said that, definitely gives a very good idea about what sort of bone we are going to deal with. Again, the templating is the one which is key here. But still, when you see an X-ray, definitely in your mind, you will know that as an young surgeon, you will know that we are dealing with this kind of bone. So what are the 3 types, A, B, and C? The first is the type A is the champagne flute, where the distal diaphysis is very, very narrow, thick cortex. Type B is regular normal bone, where it is you can use any type of stems. Type C is the osteoporotic wide stovepipe one, where it is mainly seen in old age patients and also in osteoporotic conditions, and the teaching is a cemented stem. Let us see what is the best stem for which one. But having said that, this recently published article in CRR about this DORS classification, they have mentioned about this calcar to canal ratio and also the cortical thickness index. These two, it is better to, and when you are templating, better to measure these two things, so that you need not blindly go and say that, okay, type A means this stem and type C means that stem. Based on these measurements, you can alter it. Even in type A, you can use the other stem, and in type C, you can use this stem, like that. So this is very good. And again, the templating is the key here. So you have to take a proper AP and lateral view, which was explained to you before, and the template it and measure these ratios, and you can select the stem. 62-year-old male, DOR type A. Here, the very important here is a stem like corail will be very difficult because of you have to ream the distal portion so much. So which is the best option here? A type 1 single wedge stem is a very good stem here. And most of the DOR type A canals, the type 1 single wedge stem is a very good option. So here I used an accolade stem, and is acetabular side, again, 3rd generation hemispherical cup. What is the next example? 59-year-old male, again, one more DOR type A. Here also, you can use either type 1 or type 2. Here I have used a type 2 stem. Type 2 stem, again, if you see when compared to the type 1, the length is so much. The length is quite long. So better to avoid it in a young patient, like in a 20 or 30-year-old, when they need 2 revisions. Better to avoid these kind of proximally coated double wedged metaphyseal stems in a very younger group. Otherwise, if you see the cup, it is again an uncemented 3rd generation hemispherical cup. 53-year-old female, again, look at the hip joint. It is like, it's a very stiff. The offset, it is very difficult to get a stem like corail because of the high offset, very small acetabulum. So here you have to plan, and if you look at all the ratios, the canal is very narrow and also curved. So here I have used a summit stem, which is the offset is low when compared to the corail stem. So if you had used a corail, it will be very difficult to ream the distal portion and also reduce the hip. So here the advantage to use, the better to use a design or a stem which has got a low offset. So for that, you need to know the system. That is why I mentioned in the beginning that you have to repeatedly know the system, discuss with the company people, get all the details, and then plan accordingly. Do the templating. 34-year-old female, rheumatoid, TOR type B. In a rheumatoid, you know that bone will be osteoporotic. Even though this is DOR type B, we have to be very careful in the preparation. Here I have used again a type 1 stem, uncemented. Even though the patient is a rheumatoid on steroid, I have used only a type 1 stem with an uncemented cup without any screw fixation. And also the key point here is it is a 46 size pinnacle cup, and the head size is only 28. So no need to think about putting a bigger head in a younger patient. Better to go for the correct size, because you need not over ream the acetabulum. Think about the future. Highly cross-linked poly, type 1 single wedge stem, accolade 2. So here the most important thing is the limb length and the offset. So coming to the corail stem, which is very commonly used. What is that? It is because of the ease of use and usage, and also the instrumentation is quite simple. This is widely used, and the literature also has given excellent result. It has published results about the corail system. Bone preserving philosophy, fully HA coated double wedge. This is the design of this corail system. But what is the most important thing? It has got a wide range of products. Like what is that? Starting from a 135-degree dysplasia collarless size 6 stem. It's a small size 6 dysplastic stem, corail stem, uncemented, to the high offset collared stem. So it has got everything: low offset, high offset, standard offset, collared, collardless. So you need to know the system very thoroughly before selecting which patient, which X-ray, which bone, which stem we have to use. Because corail, even though it seems very simple to use, lot of complications also happen perioperatively. So again, 32-year-old male, AVN, painful hip, pinnacle cup, corail system. Again, the key point here is the offset, leg length, and bone conservation. You have to select an implant which you can achieve these 3 things. And also try to conserve the bone, try to conserve the bone for the future. 1 year post decompression, structural collapse right side, very, very painful. Even though the patient is not symptomatic, he will left side, he will require a THR later on. But still, till that time, you have to get your length correct, offset correct to have a very good outcome and also good mobility. So 42-year-old very female, very short protrusio, thin, very, very thin, narrow distal femur, DOR type A. Here, patient is having protrusio and also 42-year-old. So what is that? Here I have used the size 6. I know it is not the right stem to routinely use, but in this situation, look at the distal femur, the diaphysis, how thick is very, very small and very narrow, and also the cortex is very thick posteriorly. In these kind of situation, if the patient is very thin built, not very obese, you can use, but you have to use it very cautiously. This is a 8-year follow-up of this patient, and it has to be used very cautiously only in a really indicated patient. Again, you can see the cup side, it is the uncemented hemispherical cup was used in this, and good results in spite of the size 6. So 40-year-old male, DOR type B. Here I have used a high offset corail stem. The thing here, the most important point here is, before itself, you should know whether you might need a high offset stem in these kind of situations. 66-year-old female, rheumatoid, DOR type C. So here we know that it is a 66-year-old rheumatoid, DOR type C, and all the ratios and index will say that this patient femoral canal is very wide. So here the most go-to implant is a cemented total hip replacement. Yes, you can keep that in mind, but still perioperatively, now the latest point here is even in literature, it has been recently published that even if it is DOR type C, definitely you can think about doing an uncemented system, particularly these kind of corail stems, which are compaction broaching, which preserves the blood supply, and it also helps in osteointegration, and an uncemented system also will help. But still, you have to keep a cemented system as a backup when you're going for these kind of situations. So this is where the DOR classification and templating helps. But still, you can go for it if the surgeon is happy with the fixation and the stability. 56-year-old male, I did this patient in 2012, post-traumatic arthritis of the left side, acetabular fracture and developed the ABN, 10 years follow-up. So it was done a reverse hybrid. That time it was done with the cemented cup and a corail stem. Now 10 years follow-up. So now this, with all these things, it's very clearly it is obvious that whether it is a reverse hybrid, cemented or uncemented, it is the design of the implant and the technique and the patient's bone quality. These are the things which matters more than the type of the system, type of the approach. So 45-year-old female, dysplastic hip, altered proximal femur anatomy. Definitely we need a modular stem. Also small acetabular cups, hemispherical cups. Here I have used an SROM modular stem, which is a type 5 stem. One more example, 50-year-old female, dysplastic hip. Again, proximal femur anatomy is altered, excessive anteversion. So you need a stem where you can control the anteversion. I have used a Cone Wagner. But this is cylindrical. The other one, SROM, is a modular one. This is a non-modular, but still you can rotate it because of the cylindrical portion. It's a titanium stem. 46-year-old female, post-valgus osteotomy. Look at the proximal femur. The abductors also, there is so much of altered because of the osteotomy. You have an implant with multiple screws. So here, when you do an implant removal, which is very common nowadays, we encounter even primary situation that DHS implant removal and THR, these kind of situations, you have to bypass the screws. So here I have used a Wagner 190 stem. So in a primary situation, implant removal and a THR, Wagner or a titanium distal loading stem 190 is the go-to stem. And this stem is very good in achieving because the offset is also quite high when compared to the primary stem. So here it solves dual purpose, getting the offset and the length. One more example, 37-year-old rheumatoid. So this patient, because of the severe arthritis of both the hips and the protrusion of the right side, patient developed a trochanteric fracture. So here the templating and the proper x-rays, the lateral x-ray very clearly reveals the fracture line, even though the patient didn't have a fall. So here, the point here is the one is the proper X-rays and the templating, which helps. And here definitely you need to use a distal loading stem because of the trochanteric fracture osteoporosis. So I have used a distal loading stem right side and a left side corail stem. The patient is osteoporotic and an uncemented hemispherical cup. So what are the, but still there are some disadvantages of this cementless stems. What is that? Proximal femoral fractures, perioperative fractures, periprosthetic, and then loosening, aseptic loosening, thigh pain, and stress shielding. To overcome that, you have to select the appropriate design. Roughness and coating of the stem is very important. Most important thing is the technique of preparation and the bone quality. To summarize, from on the acetabular side, always remember, if it is an uncemented, the go-to cup should be the third generation uncemented hemispherical cups. The coating can be anything as per your choice based on the bone quality. Highly cross-linked to poly. Yes, ceramic on ceramic can be used in a selected patients in a younger age group, but still highly cross-linked to poly. Biolox Delta ceramic heads should be the implant of choice currently. Type 1 and type 2 stems, almost it can be, this can be used in any door type bone, but given the surgeon's confidence and the skill level and the bone quality. Type C and osteoporotic bones, yes, cemented system is also a very good choice. Do not hesitate to use it, particularly in old age patients, but also keep the cemented system as a backup in your theater always. So to summarize, when there is no proximal deformity, if there is a proximal deformity or when distal fixation is needed, type 3B, C, and 4 and 5 are useful, these types. But type 1 and 2 is the most commonly used. So for a good clinical outcome, remember this, this is for the youngsters, good clinical outcome, the most important thing is getting the offset correct and the limb length. If you achieve these two, there will not be any issue at all for regarding the stability and dislocation and also the outcome. That is the femoral offset and the limb length is the relevant predictors of clinical function. The patient will be happy. For that to achieve, you need the templating and correct implant choice for achieving. So to summarize this, offset and leg length, center of rotation, bone conservation. Remember this, don't try to overream or try to select an implant which conserves the bone and also know the implant details thoroughly. This is the last two slides. This is a recent article published by Matthew Abdul and Faraz Haddad. Cemented versus uncemented hip implant fixation. Should there be an age threshold? What is that they have concluded? It is the outcome of THA determined by the fixation method. It is clear that the results are multifactorial. So you need not get fixed. Always cemented is better, uncemented is better. The outcome is multifactorial. Again, patient selection is important. Surgical training and experience are the key to success. So whichever you are comfortable with, you're trained, try to do that regularly. So the type of fixation should be selected by bone quality, medical comorbidities, and surgeon experience, and not by the patient age. So you can do any system at any age. Does cement have any significant drawbacks? Yes. Particularly keep this mind, using cemented implants in elderly patients with compromised cardiovascular state, then you will be in a state where you will see a lot of perioperative or an intraoperative complications. So try to avoid cemented particularly long cemented implants in elderly patients with compromised cardiovascular state. So take home message, as arthroplasty surgeon, we should choose an implant based on the bone quality, activity level, physiological age, and comorbidities. But if there are too many choices, then the selection should be based on surgeon's experience with one particular implant. Try to use that regularly and achieve good result. Thank you.
Thank you, Dr. Rajkumar, for that wonderful lecture with a lot of clinical cases and demonstrations. Paper, any questions? Paper is open for discussion. So if there are no questions, as we are running short of time, thank you, Raj, for that wonderful talk.
Thank you, sir. Thank you.
Now we'll go on to the essential techniques of cemented THR by Dr. Fakhruddin. So cemented THR is an art which has to be learned, and I request Dr. Fakhruddin to demonstrate.
Good evening, everyone. I would like to thank the organizer of giving this opportunity. I am going to present about essential technique to improve the outcome of cemented primary THR. As known to all, flip wheels was first invented the uncemented trolley replacement system. In earlier days, all TH implant were uncemented. The early made of TH implant were fixed to the cancerous part of the bone. So they were unable to withstand the stress got absorbed and loosening the process. Acrylic femoral head used, which was withstand the weight bearing stress resulting breakage of acrylic. In 1953, George Meck was first used the metal on metal uncemented processes. His intention to improve the strength of the processes, again which also failed. In 1970s, now come the man and the procedure of the century, Sir John Chonley. He analyzed all failed uncemented implants using the long, durable, low friction arthroplasty. He advocated to use the bone cement to fix the processes, improve the success rate. In the year of 1970, he encountered a huge number of the cases infected. The use of antibiotic cement and laminar flow in eradicate the elimination of the infection. What are the advantage fixation of the bone cement? The bone cement act like a grout, not a glue. Is a no adhesive property. It helps transferring the load from process to the bone. It helps optimal stress strain distribution and antibiotic release. Orthopedic community are extensively experienced with the use of the cement for past 50 years. Cement fixation is more durable when ideal micro interlock between bone and cement occur at the time of the implantation. Formation of such a bond is a challenge to face in each surgeon and largely depend on technical incompetence. The cement components are two: powder component, liquid component. Powder component has initiator, liquid component has a stabilizer. Heat stable antibiotics mixed with the bone cement. As quoted here, a postmortem observation study is 214 cases. Majority of the cement hip stem were not well cemented. What goes wrong? Where is the problem? Is a problem within the cement mantle, or with the problem in a bone cement interface or stem cement interface? The avoiding problem in the cement mantle is you can have a thin mantle. It's a thin mantle, or you can have a crack or a void and a blood lamination inside the cement mantle. How to prevent the cement mantle? The thin cement mantle, use appropriate stem, is a reduce the thin mantle, and use with the proper centralizer is a reduce the cement mantle. How to avoid the void? Proper pressurization of the cement, avoid the void. At the level of the problem between stem and cement interface is encountered due to the debonding. How to avoid the debonding? When at the time of the time of the cement stem inserted into the stem into the cement, do not rotate or transverse movement is avoid the bone stem cement interface. How to avoid the bone cement interface? The poor preparation of the cement is a poor cement digitation. Avoid the bone cement interface. All the above problems can be prevented by using appropriate cementing techniques. In the cementing technique from first generation to the fourth generation. First generation cementing technique, the cement mixed with the hand manual finger packing, which does not result in an irregular incomplete cement mantle, is upgrading this one. In the second generation, use a femur canal preparation, cement gun insertion, with the centralizer used, they improve the second generation technique. The most widely all orthopedic surgeons use the second technique. Vacuum mixing is a advantage of third generation, which results in better cement quality and better cement mantle. First generation cementing technique is a more aseptic loosening in more than 30% of the cases. Second and third generation cementing technique, more than 90% of all THR remain in place 10 years after implantation. More than 80% of all THR remain in place. Modern cementing technique, 97% of all THR remain in a 10 years follow-up. What is the gold standard cementing technique? To improve the cement quality and improve the cement bone interface. Improve the cement quality, vacuum mixing and retrograde application are recommended. Improve the cement interface, distal femoral plug. Use a distal femoral plug is a cement injected from retrograde cementing. The increased pressure on the cement within the canal, the better cement interdigitation. Next is a pulse lavage. Before the cementation, you put in pulsary lavage for better cement penetration. The pressurization technique, introduce the pressurization technique, better cement interdigitation with the resist the beading pressure. What is the ideal time to introduce the cement in the cavity? Cement is the 4 phases: mixing phase and waiting phase, working phase, and setting phase. In the waiting, after the waiting phase, the cement should feel non-sticky to hand or dough in consistency. The appearance of wrinkles that take the cement to reduce the canal. A lot of factor affecting the cement setting. The OT temperature so hot, the cementing setting is very fast. Excessive bleeding also affects the cement setting. Use a cement gun is ideal. Use a low viscosity cement is useful. Is the working time is good. To achieve a good acetabulum preparation, following points are considered: the circumference exposure, restore the anatomy of COR, multiple anchor hole, pulsary lavage, and cement technique. Whatever approach, like a posterior or lateral approach, I quote 360-degree exposure of the socket must, and remove the central osteophytes and the deepening of the acetabular cavity is the demonstrate. Video demonstration of acetabular preparation. Video not played. Here, acetabulum being exposed, initial rebar to floor of the acetabulum, then followed the concentric extent, multiple drill hole and pulsary lavage, remove this cancerous bone, and cement application, pressurization of the device. The pressurization device usually we are not usually routinely using. Use a larger size tile cup used for pressurization of the cement. After cement pressurization, the late phase of the polymerization, you supply a cup along with the cup inclination and 45-degree inclination, 15 to 20 degree of anti-version. The remaining cement mandibles are removed. It's anchoring multiple hole 6 to 10 mm depth is made in the floor or roof of the acetabulum, and cement application and pressurization. Cement application pressurization is good for better cement interdigitation use the cup inclination and version guided, use for cup 45 degree of inclination, 15 to 20 degree of anti-version. If anti-version actually based on the spine pathology, patient have any fused spine or the pelvic more flexed, they need lesser anti-version. The patient have a more lumbar lordosis, more anti-version. Next, the femur preparation, they use the neck resection guide at the neck, at the 45 degree angle of the neck, and use the boxer osteotomy. You do a proper lateralization and the proximal femur broaching. Canal preparation, medullary canal should be removed, progressively larger femur. Remove all the cancer bone required by cement interdigidation. The appropriate browsing, they maintain each browsing, the anti-version maintained. The critical assessment of offset and length maintained. The femoral canal preparation, after the thorough browsing, femoral canal after browsing, use a brush, remove all the cancerous bone. Posterior lavage, remove all the bone debris and the bone blood stain. Now use cement restrictor, use and give a retrograde cement handling. Use the cement gun, retrograde cementing associated with the suction catheter. After complete cementation, pressurization of 2 to 3 minutes pressurization. To improve the femoral stem longevity, need a pulsatile lavage and a medullary block insertion 2 centimeters below the original stem. Cement applied, the medium viscosity, the retrograde manner, distal to proximal, and sustained pressure or proximal to distal, improve the cement degradation. At the implant insertion at the level, is suddenly develop bone cement implantation syndrome, fall in the blood pressure, patient going for hypoxia and cardiac arrhythmia. This need a expert anesthesia management. The pulsatile jet lavage and a retrograde cement application with vacuum suction is the mandatory for prophylactic step, reduce the embolic fluid. Size of the canal, type of amount of the cement, stem size based on the surgeon choice. The good cement mandle, stem cement the ratio is 80:20, no distal load. This cement good longevity of the implant. Failure rate are high when stem is a very small alignment, can lead to deficient cement mantle and lateral the tip of the process contact to the bone is developed periprosthetic fracture. Cement mantle too thin, chance of cracking is more. The radiological assessment after cemented THR, grade A and B associated with a good clinical outcome. It's a whiteout type A and type B cement mantle are both equally good. The Ranawat et al. The CAR 1995, the yearly after immediate post-op, the cement digitation, we can appreciate here also good predictor of outcome and longevity. Modern cementing technique, key to the long-term success, improve the outcome has become proven for meticulous bone preparation and preservation, distal femoral plug and pulsatile lavage, retrograde cement application, stainless cement preservation, evidence exists better outcome, vacuum mixing bone cement, distal stem centralizer. Thank you.
Thank you, Dr. Kasudi, for bringing out all the important points of cemented total equity aspect. As you have rightly said, the distal bone plug and the centralizer and taking the stem in the central is very, very important. I thank you for that. I request Dr. Vijay Bose to hand over the memento to Dr. Dr. Rajkumar, you are there. So there are 3 questions which have come. Dr. Rajkumar?
Yes, sir.
If you're not there, I request one of the
No.
panelists to answer these questions.
I'm here.
The first question is, when is the collared oral stem is indicated?
Actually, the person who is standing there, Dr. Bose, is the right person because we both discuss about whether.
My routine, I use only collared now.
Yeah.
Generally, in door B is the ideal one that you use corail type stem. So if you have a door B, collared or non-collared is okay. But if you want to go into door C, and they also say the author group say even door A, you need to use a collar. Door C definitely, but extend the indications to door C, you have to use a collar. But mine now 100% are collared stems, all are collared stems now.
The second question is, what are the short offset uncemented?
Yeah, short offset uncemented classically are the SROM and the Cohn-Wagner stems. Now, of course, you have the short offset option with corail. I think for Indian patients, especially female, you must not do any corail stem without the short offset option that is now available. Please do not, because a lot of people we find that they are unhappy after corail stem because the standard corail is a high offset stem. So you must have our patients, Asian patients. It may work in the Caucasian population, but Asian patients, you need to female patients, you need to have a short offset corail. So that's the other important thing. Constraint liners. So constraint liners were the go-to things that you would do when you have recurrent dislocation of the hip. But now with the advent of dual mobility, the role of constraint liners have come down and down. So the one classical indication is if you have a well-osteoinated cup and you have a dislocation, then instead of reversing the whole thing into a dual mobility, you can use a constraint liner. And if, for whatever reason, if you have a dislocation of a dual mobility, then the only other option you have is a constraint liner. That's in short.
Oh, the answers were already discussed. So now we come to the very interesting topic lecture. So the acetabulum is the key for the longevity because most of the failures happen in the acetabular side, and we have to get our acetabulum right. For that, none other than Dr. Vijay Bose has come here to talk about positioning the cup, a video demonstration. Over to Dr. Vijay Bose.
Right. Firstly, thanks to Singer Radival for inviting me. It won't be here, is it? Okay. So look at that. Okay. Instead of just going to the video, I thought I'll show some slides due to 2 reasons. One, to explain the various concepts in cup positioning, you need to know some principles. So I need to. The second reason is that cup positioning doesn't take 15 minutes. So I had to put something else inside. Okay. So which is the forward one? This one. Yeah. Okay. So acetabular cup for the non-simulated cup. So the first thing is, why should one ream the acetabulum in a non-simulated socket? Why don't you just take an appropriate template size and bang it in? This is the question that I ask most of the fellows who come to our unit. And most of the answers, the commonest answer they'll give is, we want to expose the cancellous bone. How many of you think that answer is correct? That you want to expose the cancellous bone? You tell that, yeah. So most people would give, even these are, many years post MS. Well, the answer is wrong. That's not the reason why you want to. It's true that you must expose the cancellous bone in a simulated socket, but there's absolutely no need to expose cancellous bone in a absolutely wrong concept. That's not the reason why you ream the socket. So that's what the fellows and trainees say. Expose, that's not the right answer. The answer is you want to get down to the true floor. Very important. That's critical. You want to get to the true floor. 2 is to change the hip center as required by eccentric reaming. Remember that at the buildup of osteophytes, the socket becomes very eccentric. You want to make it concentric wherever you want to go. You want to go to the true level, whatever, and that you do by reaming. So that's the reason why you ream. And to maximize the host, that's the most important reason. You want to maximize the host bone contact. This is a very important point. Now, why do you ream in an IM nail? So suppose, there is say you take an IM nail and the femur, and you have intramedullary diameter of say 9, 10, 11 in that intramedullary canal. And if you use a size 9 nail, you will get only, implant host bone contact only at the 9 segment. But if you ream 10, you not get 10, you get 9 plus 10. But if you ream 11, you get 9 plus 10 plus 11. So same concept here. So if you ream and make it concentric to your cup, if you bang the cup in, you'll get only point contact here and there. But if you ream and put, you'll get complete host bone contact. And that's the reason why you ream, not to expose cancellous bone. Please do not expose cancellous bone. In young patients, we actually do not want to expose. We want to preserve bone, as Raj Kumar was emphasizing. So principles to achieve stability. These are key principles that we use commonly in revision surgery, but everyone must understand this, and you must use this in primary, especially when you come to more complex primary situations. It's absolutely critical that you understand the concepts behind it. The concepts are, the first principle is to get AP capture, which I'll go through in detail. You want to achieve toggle resistance, otherwise called as 3-point fixation. At the same time, to use the smallest component possible and preserve bone, especially in young patients. So absolutely important that that we have to preserve bone in young patient. You want to use the smallest cup that is possible for that particular socket. Absolutely cardinal principle. So this is absolute fundamental, which a lot of people do not take. When you talk about the acetabular size, people will template. You're all going to do templating. Unfortunately, you're going to template on an AP view. And what you're really templating is the superior inferior diameter. That is not the diameter of the socket. That the diameter refers to the AP diameter of the socket, which unfortunately you don't see in the. So when you have a dysplastic socket, for example, you have a large superior inferior diameter. That's not the socket that you want to put in. You want to put in a socket that matches the anterior inferior diameter, which is the true diameter of the socket. Okay. So remember that when you're templating, although you're not seeing, you want to actually match the AP diameter of the socket. So capture refers to engaging the cup in a minimum diameter. So that's what you mean by capture. So typically in any socket, it would be the AP diameter. That will be the minimum diameter. Superior inferior typically is the largest diameter. So when you want the AP capture, you have to engage the cup in one diameter, minimum diameter, usually somewhere between the posterior and the anterior columns or walls. So how do you know you've achieved the AP capture? During the surgery, you rotate the cup. So if you're not able to rotate the cup, so any cup that you see, if you're able to, even if you engage one diameter, the shortest diameter, you'll be able to move the cup around, but you won't be able to rotate the cup because engage that's what we call as the AP capture. AP capture results in cup stability if the socket is perfectly circular. So suppose if your socket is perfectly circular, AP capture will, that's all you need. But rarely in life that we see a socket that's completely circular. Usually it's oblong. Or most sockets slightly oblong. Therefore, some tilt may be possible. So although you may establish AP capture, still some tilt may be possible. Now, this is the tilt or the toggle. Toggle refers to the tilt that occurs perpendicular to the AP capture. Typically, you'll, somewhere the AP will get a capture, but will be able to toggle. That's known as the AP. So you have to eliminate toggle as well to get stability of the cup. So how do you eliminate toggle? You can upsize the cup to get a third point. So remember that any object, as long as you have minimum 3 points, will be stable. Nothing can be apart from living things. Inanimate things can't stand on two things, like a tripod. But if you have three things to stand, then all inanimate things will stand. So you'll have minimum 3 points. You can get 20 points also. That's great. But minimum you need is 3 points, and that's the principle that we want to talk about today. So toggle can be eliminated by upsizing the cup, thereby making the slightly oblong socket circular. So here's a cup. You put a cup that matches the minimum diameter. So in theory, you get AP capture, but you get toggle. So you can put screws and try and eliminate, but better thing to do it 1 or 2 millimeter, no harm done. So you want to just, in most of the primary situations, will be like this. Put a slightly larger cup and you get 3-point fixation. And then your cup will be stable. And that's the principle that we're trying to achieve. The more complex sockets you do, you got to understand this principle. So that's the thing that I'm trying to show in the video. So if you cannot, for division situations, for example, you cannot upsize, you'll run out of bone anteroposteriorly. So what do? You put multiple screws and try to eliminate the toggle. But remember that a cup that does not achieve AP capture, whether the primary or the division situation, will fail. You have to achieve AP capture. So if you have, we call minor toggle is eliminated by screws. You have a major toggle, you have to put an augment. That's simple. That's all there is to it, to socket preparation. So what's the target for cup positioning now? In 2022, how are we trying to position the cup? Well, we want in the post-op standing X-ray, it must look like this. Parallelism of the components with soft edges, not sharp edges, indicates good positioning in both the coronal and the sagittal plane. It's not only the coronal plane you're talking about. You also have got good positioning, although we don't see it on the AP X-rays, also in the sagittal plane. Both version inclination has been taken off if you get parallelism of this. That's what you're aiming for today in the post-op X-rays. So the real question, if you ask me what angle you want to put, there's no strict answer. So the answer is we do not know the exact position that we're aiming for, but the concept of avoiding edge loading and impingement in both the planes, coronal and sagittal planes, you're avoiding edge loading and impingement, and that's what we want to. So biomechanics of the native hip or whether the same thing will apply to the native hip also. Native hip and or the prosthetic hip is the same. So 4 variables in cup positioning, remember that. So the depth of the medial lateral position, the height of the superior inferior position, the inclination, version. That's all only, there are no other variables. If you get this 4 thing right, that's it, all done. So reference place you must know for all these 4 things. So the medial lateral placement is the Kohler's line. So here are 2 cups that are not placed correctly. 1 cup is gone much further to medial to the Kohler's line, bad surgery. 1 cup is kept much away from the Kohler's line, bad surgery. Teardrop, 1 cup is kept really below the teardrop, very bad surgery. 1 cup kept higher up, may not be great surgery. So the superior inferior, the inter teardrop line tells you, inferior limit of the teardrop tells you where your cup is good or bad. So if you don't get all these right, you'll have problem with limb length, offset, operator power, impingement, gait pattern, trochanter symptoms, polywear, early failure. All these things will occur. So it's very important to get all these concepts right. Now pelvic obliquity we all know. We're all very familiar with that. So we have the inter teardrop line, the horizontal, we know the pelvic, the oblique. Obliquity we all know. Fixed abduction deformity, adduction deformity, etc. But what that we should really give importance to that we don't is the pelvic tilt or sagittal plane. Now, in my opinion, may not be, some may not agree that if you don't take a lateral view of the pelvis, it's like taking a knee, only AP view of the knee and assessing various things. I'm going to do this, I'm going to do this. You're not taking a lateral view of the pelvis. So in our unit, every patient will get a lateral view. That's absolutely fundamental. So this is the line that not many understand. This is the sacrocoaxial line, midpoint of the S1 to the femoral head. That's sacrocoaxial. Just like how you wouldn't dare do a hip without looking at the AP view, you shouldn't be doing anything without looking at the lateral view. That's what it tells you what it is all about. And the line from this is to the horizontal, that's a vertical. That tells you the pelvic tilt. This is pelvic obliquity, that is pelvic tilt. It's very, very, very simple. Another axis for, when you go to robotics and all that, they'll talk about the APP or the anterior pelvic plane. That's also another reference for the pelvic tilt. It's pelvic tilt is as important as pelvic obliquity. Remember that, say, suppose for a cup, if you see there's a fixed deformity and you didn't compensate, you just put the cup the usual way for a fixed pelvic tilt, what will happen? Disaster. But you never even take a lateral view and you just put a cup. I mean, they're just not on. So it's equally important. Pelvic obliquity in this plane, pelvic tilt in this plane, you've got to understand that. Absolutely fundamental. So not compensating for pelvic tilt will be equally dangerous, as dangerous as not compensating for pelvic obliquity. So how to compensate, I'll not go into that, but you need to take sitting and standing views. So whenever you find the operator foramen is not, that Ranavar has described, cat's eye open and cat's eye closed, that means there's some pelvic tilt. And that's what is manifesting as the cat's eye open or cat's eye closed. So you need to do something, find out what is the problem and how to deal with it. I've not go into it all in detail, but that's the essence of it. Yeah. So these are the 4 indices that we know that the Kohler's line, the teardrop line, so if you get all these right, your cup is perfect. That's what you want to, and you've done a very good job. If you get all these and the 4 things correct, it's all done a very good job. So what has changed in recent times? The Lewinick safe zones were well established earlier, but now we know it's absolutely not valid. We are now understood as a thing also the pelvic tilt or the spino-pelvic relationship is very important. Recognition of spatial relationship and femoropelvic parameters. A lot of the spatial relationship is now more important than absolute parameters. Ideal component positioning, the parallelism if you get, you probably will give you the maximum longevity of your THR. So this is a surgical video. So this was done elsewhere from Ahmedabad. So he has come to me for the left side hip. Can you switch on the video, please? Yeah, so that's the thing. So templating is all great, but for me, the real issue is to measure the size of the head. That in real life tells me what is the size of the socket. So I cut the femoral head. We can off the noise, please. I'm measuring the very, very important for me, measuring the size of the head. So the socket must be 4 millimeters more. That's it. That's the best template. No magnification, no nothing. Everything is set there. Okay. So we start reaming first. There's always a false floor and a true floor. So we always have to go to the true floor in all 100% of cases. There is no other view of it. You must ream it and go to the true floor. So we are, you can see that the pulvinar fat pad is there. And once I remove the pulvinar fat pad, the osteophytes will make the false floor and the pulvinar fat pad base will be true floor. With the Charnley curette, I'm taking it out. And there is no exception where you want to keep the cup. Rajkumar was talking about high hip center. Yeah, there are situations we'd like to go high hip center, but no indication where you want to keep the cup laterally or medially. No indication. All one, you have to go to the true floor and keep. That's it. All indications. So I'm taking off the true floor. As I told you, that's the objective of reaming the cup. So I'm going till I reach the true floor for all cases, 100% of cases. No exception to that rule. So I'm reaming that. Now, we are just by measuring the head, we know the size of the cup. We also know the size of the stem now. So that's such an essential thing for me. So that's how I mark the tal. There are a lot of inferior osteophytes in this case. So I put an artery fossa from the other side, and wherever it drops into the operator foramen, that's where the tal is. So although I have not seen the tal, I'm marking the tal because I want to keep the cup usually along the native version, as we call it. So I'm marking the tal from the inside of the cup because I'm not able to see the tals covered by osteophytes. Now you can see that the my reamer is now parallel to the tal, and I'm going to put a small artery forceps here. So that also takes care of my inclination and version. That's where the tal tells me for this particular socket, the inclination and version should be. So we're going to ream along that. From now on, the artery forceps will be the guide. Every time you don't have to look at the tal. So I start reaming and I keep expanding till I get what? AP capture. Till I get AP capture. So more experienced surgeons will be able to appreciate AP capture on the reamer itself. But here I'm putting, and look at that, I'm rotating. That means no cup. So if somebody thinks a cup that doesn't have AP capture, I'll put 4 screws and make it stable. No, you can never make that stable. You need to have AP capture for cup to survive. So now I expand the cup by 2. I put the next size trial inside. And now I find that I'm not able to rotate. You can see that I'm trying to rotate. I'm not. I have AP capture. However, you can see it's toggling. Usually in a plane perpendicular to the plane of AP capture, you find toggle. So I'm going to upsize one more. So now I'm upsizing one more, and I'm putting the next higher size trial inside. And here I find there is no rotation. That means I got AP capture. There's no toggle also. That means this is the size of the cup. There's no reason you must expand it beyond that. You got AP capture, you got 3-point fixation or toggle resistance, you got. That's it. There's nothing to remove. Now you can see how. So now again, I'm going to mark my tal. Now I'm going to take one cup that is 2 millimeters smaller, just a smaller cup than this. And I'm going to again fine tune my version because, the pelvis could have moved. So many things could have happened. So I'm putting my, what we call as a 1-down cup. So one size lower cup, which I can move around, and I'm down fine tuning now. That is the axis that which I want to put my cup. That's it. Okay. Now that's the preparation. So we don't want to ream anymore. We're ignoring all the superior landmarks. We're completely ignoring. We're using only the inferior landmarks. And if you are going to have screws, we usually mark the 12 o'clock of the cup so that you can either put the cup clockwise or anti-clockwise, depending on where the bone stock is. So never put it at 12 o'clock at 12 o'clock. You have to either put it anti-clockwise or clockwise. So we are putting it there, and I'm aligning it to the artery forceps here on the skin, and that will give me the version and the inclination that I want. And in this case, it's the avian case, it will be just native version and inclination. So I'm going to bang it in. In primary cups, you must try not to use screws. It's all a question of preparation. So you can see that it's going in nicely. And you can see it exactly on the artery forceps, exactly where I wanted to go. It's gone where it should go. And we are very confident of this fixation without screws. So if you start putting screws, you will never get your technique right. So this is famously we call this the Boyle's test. So your fixation must be so good that if you rock the pelvis must rock, the Boyle's apparatus and anesthetist must all rock along with it. So we call it as the Boyle's test. You can see that we rock it in all the patients. So it's like solid. There's no question of it coming out. So you wash the socket. And this particular system has got a 10-degree hood. Whenever you have a hood, mark where the apex of the hood is with a pen, and you must rotate it. Never put the hood anteriorly. Never ever put that. I found, people think it's unstable anteriorly, they will switch it anteriorly. It will 100% dislocate. So you can either give a little more posterior or a little less posterior. You never go anterior. So we mark the hood, we put the cup inside, and bang that thing inside. So that's how we do for all our cups. So we follow this technique over the last 20 years. I've been doing hip arthroplasty. In primary situations, we have not had a cup loosening for the last 19 years. Initially, we had before we knew the technique, of course. So go on, please. Next one. No, the next one, please. Oh, I have the thing. Yeah. So this is the one. Okay. So conclusions, last slide. The acetabular component positioning, as Dr. Singaravadi said, is the most important variable influencing outcomes of THRS. Stem and all is important, but the most important is the socket. The functional safe zone now, with all these parameters, are much more important than the Levenick safe zone. Individual femoral acetabular parameters are getting more and more irrelevant, and the combined parameters are getting more and more relevant now. Parallelism of the component of the coronal plane in a standing X-ray, the neutral position of the limb seems to be the best goal in terms of avoiding impingement on one side, so that you can avoid early wear. So, you don't know exactly what position to aim for, but if you have parallel, you'll find that you are edge loading, and we don't want to avoid impingement and edge loading. That's the thing. To avoid that, if you have parallelism in both the planes, both the versional and the inclinational plane, then you have achieved your target. Thank you very much.
Thank you, sir, for the wonderful demonstration. I know that each and every sentence what he spoke carries a lot of meaning, and you take a lot of time to assimilate whatever he has told, and you may have to listen to it again to understand everything, because acetabular cup positioning needs a lot of technique intensive, and don't think that just keeping it as you were telling that it is going to give the result. Any questions?
Yes, so I agree that the simplate cannot be as accurate as your unsimplate, because as Rajkumar was emphasizing, it's not a hemispherical cup. A lot of things taken by the cement, so it's not as accurate. But we use the same principles and we try and get it. But of course, you don't have to get AP capture and all that. Cement will take care of all of that. But the accurate positioning is not as good as unsimplate. I take that point.
When there is a crossover sign, or you expect retroversion. So what are the other landmarks you have for positioning acetabular cup? Is it only the positioning of the patient or anything else you have?
Yes, so the first thing is pick up the crossover sign on the X-ray. So we know that the crossover sign denotes acetabular retrotorsion. So it's anatomically going to be more retroverted. So we're going to give more inclination as we have. So for people who are early on and you don't know how much as the rule of thumb, it's best to leave a trial socket in, do your femur, and then look at the combined. Combined antivulation is the most critical thing that we're looking at. So even when we take the spinopelvic parameters, for example, somebody has got a fixed, lordosis, angstpon. So we want to compensate. How do we compensate? So what do we mean by compensation? That means we want to reduce or increase the combined antivulation. That's the final goal. You may do a lot of things. So final goal is to either reduce, depending on the lordosis or kyphosis. You want to either increase or decrease the combined antivulation. So if somebody has similar retrotorsion, we try and antivert the cup a little more. By experience, you can do 5-10 degrees. But if you don't know what to do it, just keep your trial socket, come to the femur and see where it is. We find that that it's too less of antivulsion. The combined antivulsion is only 15 degrees. Then you got to get more version in the system. So you try and antivert the socket more, you try and antivert the femur more. So you want to achieve a goal of about 35 degrees. So that's what you do in real life. And again, the reverse also true. Suppose angstpon patient kyphosis, you find the target is antiverted, you don't know how much to retrovert, then you leave your trial socket in, come and do your femur, go back, see how the combined version is, and try and modify both on the femur and on the socket, so that you get the ideal of around 35 for our patients.
Then the trial should be a little lesser.
Yes, trial cup.
So that when you bang it, then you may not be able to change and you may have to upsize it.
Like I showed you, even the trial cup, you have to demonstrate AP capture and toggle resistance on the trial cup itself. So you have demonstrated that already. So the cup is typically, you must know what is the difference between the actual cup and the trial. Usually, for example, the Pinnacle cup is 0.6, which is a very good one. So even though trial is stable, you'll be able to take it out, you'll be able to bang the real one in. But something like a striker cup, the differential is 1.6, very high. So for that is a little different. But for Pinnacle cup, for example, the difference only 0.6. So trial is stable, you can pull it out, bang it out, and put a real cup, which you cannot take it out.
Thank you, sir. If there are no further questions, I request Professor Govardhan to hand over the memento. we come to the very important problem of THR. We quite often see in inflammatory or other so many diseases that we see a protrusio. How to manage a protrusio in total hip replacement? Over to the exponent of various surgeries, Professor Govardhan, for explaining to us.
Can we have that? Oh, right. But it is not reflected here. Thanks very much for being here, even at 9:30 in the evening, braving your, thank you. Okay. This one is the next. Okay. Keeping yourself hungry and when the food is served there. Thanks very much, Dr. Singaravadivilu, the OASIS members and TNOA members for giving me an opportunity to talk on THR and protrusia. Protrusia is divided into two varieties. One is a primary variety, which was actually described by the Adolf William Otto, a German pathologist, in 1824. It is usually bilateral. It affects the females more often. It is associated with protrusion of the medial wall, with pain and limitation of the range of movement, where femoral neck becomes more varus. This is the primary. But let us see some of the example. Now, this X-ray shows that the patient has got some osteoporosis. The medial wall is a little bit hazy. We are not able to see the head of the femur properly. 20 years ago, if the X-ray is shown to any of the postgraduate, he will say, this is tuberculosis of the hip. This is the infective pathology where there is a protrusion. This is a X-ray which shows that bilateral protrusion is there. The bones are very osteoporotic. There is a pathological fracture of the left femur, wide medullary canal, and this is a metabolic problem, probably an osteomalacia. Third variety, which I am showing, is one side of the hemipelvis is normal porotic, whereas in the opposite side, you can see that it is sclerotic, probably. It's a Page's disease, wherein you can get a secondary protrusion. This is very, very easy to diagnose. A acetabular fracture, where there is a central type of a dislocation with protrusion, which is a traumatic one. This is very rare, where you can find a benign tumor like hemangioma, which can cause protrusion. And this is one of the very rare variety which one can see is spondyloepiphyseal dysplasia. This is protrusion where the bones are very, very porotic. It is malformed. A lot of fractures have happened. Child has got blue sclera. It is an osteogenesis imperfecta where there is protrusion. And that is most of the challenging part of most of the arthroplasty surgeons, where they get aseptic loosening of the component. This is a young gentleman whom I see some 20 years ago with this picture where the bone was missing above. I didn't know what it was. So I did a biopsy and found that it is a hemorrhagic one. There was no bone there at all. And we took the biopsy. With the biopsy, we found out some hemosiderin granules are there. So I didn't know what to do with this because we had jumped on the bone biopsy. Then we did various radiological investigations and found that he has got a parathyroid adenoma. And that was a Brown's tumor. So treatment for that is you excise the parathyroid adenoma, the bone reforms. No need for any surgery for that. This message, I got it from Professor TKS because one of the patients, I operated one of his patients where patient had parathyroid adenoma, but pathological fracture of the femur, which I just nailed it, and he put plaster, and he said that this will heal. And he sent the X-ray after 6 months later. Once the parathyroid adenoma was removed, the whole bone has healed. So I did not do anything. Only we removed the parathyroid adenoma and the bone has formed. So these are the various secondary causes for our protrusion. How to diagnose? Very easy. Break in Kohler's line and CE angle of more than 40 degrees. If the deformity is progressive, you can find that the greater trochanter impinges on the pelvis and it is usually associated with coxa vara. What is the principle of reconstruction? Restore the hip center to the anatomical position. A hip center can be accepted up to 5 to 10 millimeter above the hip center. Cavitatory and segmental defects in the medial wall to be impacted with bone graft. Impaction bone graft is the key word when you are dealing with any of the protrusiae. Intact peripheral rim should be utilized to support the acetabular component. That is another key word, because you have the intact rim, but medial side, medial wall, the floor of the acetabulum is cavitated. So once you have impacted with the bone graft, and you get a good hemiscapal contact on the floor as well as on the rim. Find out the center of the rotation of the hip may be very difficult if you have got a more protrusiae, and protrusiae could be not only medial, but also it may be destroying the superior side. Some of the example I will be showing. Ranawat, Dor, English have shared the Shenton's line as well as colon line and height of the pelvis to determine the center of it. But it is not practically possible when you are doing the surgery. Probably the loss of bone superiorly and medially has to be assessed on the table, and you have to bring your own experience to find out. Always bring the cup inferiorly to the level of the tile and laterally to correct the vertical as well as the horizontal offset. Otherwise, the impingements will happen. Example of a patient, he's only 19 years old, male. This fellow within 1 year had this fate. He was operated when I was at Government General Hospital. I use usually a posterolateral approach. You have to identify the sciatic nerve when you're doing a protrusia, because sciatic nerve may be very close to the great trochanter. So avoid injury to that, you have to identify. If the limb is in external rotation and abduction, it will be absolutely impossible to find out where exactly you are dealing with the greater trochanter and lip of the acetabulum. So one has to definitely identify the sciatic nerve. Go through the floor of the trochanteric base and then cut the external rotators. Once you have reflected them, you will see the capsule of the hip. The capsule has to be cut posteriorly, superiorly, and C inferiorly. Once you have done that, then you will be able to toggle that hip. Otherwise, it is not possible. If there is some movement there, it is fine. If there are no movements there, you have no other choice but to resect the head. Release the deep attachment of the gluteus maximus to protect the sciatic nerve. Detach external rotator, capsule all around. Dislocate the hip will be very difficult. Now, release the capsule all around. If you are not able to do the dislocation, resect 2 to 3 millimeters of the rim. Excise any osteophytes. Usually the rim from the posterior side, if you are able to get it out, you will be able to get the head out of it. You can also use hooks to pull the head laterally. Will help in dislocating the hip. If dislocation is not possible, resect the neck and remove the head separately. Sometimes I've used 2 incisions to resect the neck, because it was just not possible to do the resect. Because I use posterior approach, it was not possible to identify where exactly we are going to cut the neck. So anteriorly, you can make a vertical incision of Smith-Peterson. You can find out the neck very easily and cut the neck at that level. Once you have got the head, you have to use the head as a graft. So denude all the articular cartilage and get the cup in that. And that is the type of reaming what you have to do, which is shown in this diagram. You have to preserve the bone and the periphery. Once you have done the reaming of the periphery, you will know you should not use the smaller reamer first. You should use, you can trial with the cup, trial with your reamer. What reamer fits to the rim, that is the reamer which you have to use first. And you should not go right onto the bottom of the acetabulum. If you go right onto the bottom of the acetabulum, you will never get any of the hole, because there is so much of bone loss. And you can go 1 millimeter each, get a good fit, as Dr. Bose was talking about. You get a good fit antero-posteriorly and superiorly and inferiorly possible. Then you put the graft inside. do a reverse reaming, you will be able to put a nice cup that is pre-op and post-op. This is a lady who had rheumatoid arthritis. One side, she had the replacement done. She delayed for 2.5 years. You can see how much is the progression of the disease, where the left side has gone not only medially as well as superiorly. I have a lot of examples of acetabular fracture, and one of the acetabular fracture where you cannot dislocate, you can do the osteotomy of the neck. You can deliver the head. Before resecting the neck, you take off all the articular cartilage when you are dealing with an acetabular fracture. Get the graft ready, pack it nicely, impact in the floor, and you will be able to complete the procedure well. This is one more example where we were not able to get the head at all. So what we have done is we have resected the neck and then defined the edges of the acetabulum. We did not remove the head at all. Onto the neck itself, we reamed it, and this is actually the resected portion of the neck and head remaining. And that is the post-op. This is the boy who had the spondyloepiphyseal dysplasia. He is a son of a Prohit in Salem. This boy is still coming to me. He had this, and as Dr. Bose was pointing out, you have to see the anteroposterior diameter rather than the superior to inferior diameter, because they are always more. So we have really found it very difficult to put these cups, and they were done in Government General Hospital, recommended by one MP from Salem. He had equal limb length. This is a common scenario where after the hemiarthroplasty, you can get osteolysis like this. They can be very well assessed if you do the Jude views, because the anterior as well as the posterior columns can be very well delineated. Once you know that, you can put an impaction superiorly as well as the medially, get a good fit with the uncemented cup. Because we have done the bone grafting, we have also used 2 of the screws. This is 1 year follow-up. You can imagine that most of the grafts which we put, they should be able to sustain. Some of them, they do fail, but in this particular case, which is an aseptic loosening of the hip, we have done the impaction grafting superiorly and medially, got hold of 3 screws above and completed. But unfortunately, this fellow developed an infection at that level, which was taken care, and then that healed and end procedure. You can see that nice incorporation of the graft with lamellar bone formation in this case. It has stood time, 10 years follow-up is there. This is 4 years follow-up with infected hip. First, it is a 2-stage. This is our own made spacer. Revised is 1 year follow-up with good incorporation of the graft. One more acetabular fracture with, that is the floor. If you do the 3D imaging, you can get a cup here at this level because it can hold, you can hold anteriorly and posteriorly, and that is a defect which you have to fill it up. In the acetabular fracture, if it is old, it is 4.5 years old fracture. So you have got a lot of bone formation, and it was easy to do this surgery to get the cup at the original level and lateralize it so that you can get a vertical as well as the horizontal offset right in this particular. This is 9 years follow-up. That's a range of movement what this gentleman has got. Not all our hemis will do well. She's 84 years old, fell again after this hemiarthroplasty, and she has broken the floor of the acetabulum, as well as she has got break here, but she wanted to walk. So in such situation, it won't be possible without a shell like this. So we put a shell with bone graft, lot of bone graft, and a cemented one. Shell orientation and cup orientations are different. Shell is for holding the graft which you are going to put. That is 2015, this is 2019. It was a very interesting chap. As soon as you see this X-ray, you will know where this operation was done. Trochanteric osteotomy, cemented hip replacement. He was only 24 years old, fracture neck of femur, treated with total hip replacement. In 2000, he had the loosening. In 2003, this was revised in Hyderabad. In 2005, that was the situation where he landed up to me and the cup was just floating. You can see that there is a huge amount of bone loss superiorly and medially. In such situation, at that time, after analyzing everything, I used the octopus cup, which was available. Octopus cup will have a good hold in the ilium as well as the operator foramen level. And you can use a lot of screws. So I was very, very happy that this fellow I could revise and get the cup in original position, got the version right, the offsets and all, everything is right. This is pre-op and post-op. 2014, you can see that the whole graft, which I put, 4 of the femoral heads, which we preserved, has been put as a graft. But you can see that it is slowly invaginating and the cup is also moving. That's 2018, this is the situation. And that is 2021. He has got now pain. You can see that the hook is looking like intrapelvic and he has got pain. He doesn't want to come for any surgery now. I don't know what we are going to do. That's the last example, I think. 14 years post-surgery. It's a cemented hip which has been done. You've got a large defect there. You've got a bone cement which is lying there. And that is the oblique views which shows the anterior column is also defective. Posterior column is also defective. We did some studies with 3D reconstruction, found out that even the posterior wall and columns are very much defective. So unless otherwise you do more of an anti-version of the cup, it is not possible to contain this. So at the time of this, since there was cemented stem, we did a extended trochanteric osteotomy, which very rarely you will do for a primary one, but here it's a revision one. So to remove the stem properly, we did a extended trochanteric osteotomy, and that is a cup which is lying loose. These are the components which we removed. That is the area of the hole which we have to deal. That's big. And none of the reamers could accommodate except 70. And 70 reamers are not available. So we just used the 70 trial and found out that that is a. So our options were for the superior defect, you can use an augment, TM augment with a 70 mm cup, or use a 70 mm trabecular metal revision cup. On top, you can put another cup in cup technique, so that you can lateralize the shaft very well and you can get the offset right. There was a lot of debate going on. So I said, okay, we will first put the 70 mm trabecular cup, and that was done. And you can see that that totally filled the gap. There was hardly anything there up, but very nice fix anterior posteriorly. Of course, we use 3 or 4 screws. On the femoral side, we use the revision Wagner stem, and that is the post-op X-ray. You can see that amount of the graft which we have put. This follow-up we will tell you later. Oh, there's one more example. This is our metal on metal, which has failed. And we had this removal of the component, and loose cup was easily removed. And we did the grafting, used the trabecular metal revision, and that is the, this is 6 years follow-up now. On the other side also we revised it. This side also revised it. So after the revision, both sides you can see that the lesser trochanter are level each other. They have got equal limb length. So some summary, protrusion is a difficult problem. Depending on the pathology, one has to plan the surgery. Most of these metabolic and other diseases were very rarely we will be doing any surgery on them. But if you have got a Paget's disease with pain, you have to do the surgery. Protrusion of the floor alone is easy to manage with impaction grafting and uncemented cup. But if there is a both proximal and medial migration of the head, getting a stable cup in the anatomical center of the hip is very difficult. We may need augments, we may need jumbo cups, we may need cages to get a stable hip with correction of vertical and horizontal offset. We should always forewarn the people because they all will be worried about limb length discrepancy. We should not give any promise that we will be able to get a absolutely equal limb length on both sides. And I usually tell them that I will try my level best to get the equal limb. Thank you very much for your patient listening.
Thank you, sir. Thank you for that wonderful lecture and bringing out all the key points and telling us about how to proceed with protrusion. Any question? So, if there are no questions, I'll take the honor of handing over the memento to you, sir. So now we have come to the conclusion, and I thank all the faculties for having devoted their time and having come here and given us their knowledge and wisdom. So I hope that everything was useful, and I thank all the delegates for remaining here till this late time, as Dr. Gordon sir was telling. And when the faculties are right and what they are delivering is good, then I'm sure that all the delegates will stay here, and it's very happy to see that everyone, the hall is almost full. So I thank the delegates, and I thank Deputy Johnson & Johnson for always, as usual, supporting all the scientific and academic endeavors. Now I invite you all for joining for the dinner. And yeah, some refreshment is also there for the fellowship at this late night, people who don't mind. But take care, and when you are going back, yeah. So be responsible citizens. Thank you. I also thank the OASIS for having given us this opportunity once again. And I thank all the delegates who have joined us online and remaining with us for their participation. Thank you.